Good morning from FOGSI ICOG tutorial. Today, another second Sunday of the month at 11:30 a.m. We are here with another program. Today, we are going to discuss cases on prematurity and preterm labor and pregnancy beyond expected date of duration. So we have these two cases. These are the two very common clinical problems and very common situation in the exam also. So these cases we are going to discuss, and we have students Dr. Priyanka Raghav and Ayushi Gupta from SN Medical College, Agra, and Dr. Ruchika Garg is the coordinating faculty from there. We have another case that is pregnancy beyond expected date of duration. The students are Dr. Ankur Pandey, Dr. Karishma Prajapat from Deen Dayal Upadhyay Hospital, Delhi, and we have Dr. Shashilata Kabra as a coordinating faculty. Today we have experts, teachers, and very prominent person from the country, different parts of the country. As usual, we have Dr. Ashish Upadhyay sir, who always there. And the purpose of this program is always that we highlight how to present the cases in the exam by a PG student. We are not insisting that what should be done, but what is expected out of our PG student. And we always insist on making a diagnosis and making a summary of the case. And Dr. Ashish definitely looks into that. Then we have Dr. Urvashi Barman Singh from Allahabad, Dr. Sheila Jamal from Bareilly, Madam respected Jayam Kanam from Chennai, Dr. Apurva Kumar Bhattacharya from Assam, and Seema Grover from Faridkot, Punjab. So with all these expert faculty, teachers from different parts of the country and the students from Agra and from Delhi, today I hope we will have a very useful and beneficial discussion for these cases for our student to prepare for their exam. And I'm very thankful to President FOGSI, Dr. Rishikesh Pai, ICOG Chairperson, Dr. Lakshmi Srikhande, for their blessing. We are having this program, and now for last almost 2 years, continuously we are running this program on second Sunday of every month. And I have with me Dr. Ashish Mukhopadhyay and Dr. Hafizur Rahman, who always there to prepare, to organize and to run this program in a very efficient and successful manner. So today, with all these words, I would like to start this program, and I invite our ICOG Vice Chairperson, Dr. Parag Biniwala, sir, to say a few words.
Thank you, Dr. Ashok. Good morning, all. I bring greetings from ICOG, the Indian College of OBGYN, which is the academic wing of FOGSI. And it's a pleasure to connect with you all once again with another episode of the PG tutorials. This is a brainchild of our Secretary ICOG, Dr. Ashok Kumar. And we have Dr. Ashish and Dr. Hafizur, who are taking charge of this program. And three of them together are running this program very, very successfully. The sole purpose of this program is to get an exposure of outstation faculty to our postgraduate students. And that is how they will understand the subject better. They will be exposed to different thoughts. And after all, when they appear for exams, it will be a great boon to all of them. And I'm thankful to all the examiners. When we have seniors like Dr. Jayam Kannan, welcome madam, Dr. Apurva, and of course Dr. Sheila, who are our examiners, and thank you Dr. Ruchika and Dr. Shashi for being the coordinators today. And I look forward to an exciting learning session this morning. Thank you very much, all of you, and enjoy learning.
So thank you, Dr. Parag sir. With his advice and with his comments, now we start the program. And Dr. Ashish, would you like to start and say a few words before starting?
Yes, sure. Thank you very much. Thank you, Dr. Ashok Kumar, and my respectful regards to the FOGSI President, Dr. Rishikesh Pai, who has been always very encouraging about this program, and our ever enthusiastic, always beaming with energy, Dr. Lakshmi Srikhande, our chairperson of ICOG, and Dr. Parag Viniwale. I haven't seen a better, more handsome person, more smiling person than Parag Viniwale, and he has been always encouraging us. Thanks also go to Dr. Madhuri Patel, our Secretary General of FOGSI. Today, once again, it is the second Sunday of the month of May, and we are here. And as Dr. Ashok Kumar has said, we have been running this program for the last 2 years, and the purpose is basically helping the students in presentation of the case. This is the foundation stone or building block of their future presentations in life. So many presentations they will have in their future, but I always say the most important start of journey, which I was discussing today with Dr. Jayam Kannan, is this 3-minute presentation of their case to the external examiner, how to make a presentation of a case. I have been advised many models, which I have circulated all over the ICOG, is available in ICOG website also. And with that introduction, I would like to invite the first case, that is a pregnancy with preterm labor. And this is going to be presented by Dr. Ayushi Gupta and Dr. Priyanka Raghav, who are from SN Medical College, Agra. One of my favorite haunting places for the FORCE program. And Dr. Ruchika Garg is the moderator of this program. Ruchika was stuck in a case of placenta accreta. Fortunately, she is free now. That means placenta accreta has spared her. So let us welcome Dr. Ruchika Garg and the two students, Ayushi Gupta and Priyanka. So Ayushi, are you ready with the presentation? Have you opened your presentation, Ayushi?
Ayushi, start slides sharing.
She has done just now, so I think she'll be able to do that.
Yeah.
Yes.
Yes.
Ayushi, make it full screen, please.
Yes, sir, I'm making. Sir, am I audible?
You're audible, but your screen is not full screen yet.
नीचे जाके करो.
Go to the full screen mode. This is the full screen mode.
Sir, I've already done it.
Okay.
इधर नीचे.
No, then click the this thing,
Coming
enable
in the
editing.
form of slide share.
Click
Sorry,
on
sir?
this enable editing first. Click on this enable editing first.
Enable editing. Click.
Click on the enable editing button in the screen. Then only you will be able to do it.
Click on enable editing. ऊपर जो बेटा येलो लाइन पे enable editing लिख रहा है.
Ma'am, it's not coming in.
आप एक काम करिए, जस्ट एस्केप का बटन प्रेस करिए.
Yes, sir.
ओके, अभी आपको फुल स्क्रीन से बाहर आ गया.
Yes, sir.
हाँ.
Sir, is it okay now?
Yes,
Okay,
now
done.
now it's
It's
okay.
full screen now.
So you start, Ayushi.
Okay. Good morning, respected teachers. My name is Ayushi Gupta. And my name is Priyanka Raghav. And we are from SN Medical College, and we are presenting the case on preterm labor. Now, the patient particulars. I am presenting the case of Mrs. Sharma, 29 years, female, resident of Loha Mandi, which is 5 kilometers from our hospital, housewife and illiterate. Her registration number is 20230 and date of admission and examination being 11th of Feb. She presented with chief complaints of pain in lower abdomen for last 8 hours, along with amenorrhea for 8 months. This was her first antenatal visit. History of present illness, pain in lower abdomen, which was for 8 hours, dull in nature, insidious in onset, starting from lower back, radiating to lower abdomen and thigh. It was mild in intensity, gradually increasing in intensity, and coming at half-hourly interval. Associated with tightening of abdomen and with blood mixed mucoid discharge. Pain was not associated with any leaking per vaginum, no history of any blow or trauma over abdomen, no history of coitus recently, no history suggestive of urinary problem. pain was not relieved by any medication. There were no relieving or aggravating factors. History of present pregnancy. First and second trimester were uneventful. There was history of lower abdomen pain, lower back pain, and blood-stained vaginal discharge in third trimester. Menstrual history. Age of menarche was 13 years of age. Her past cycles were regular from around 28 to 30 days, lasting for 3 to 4 days. Her LMP was 12th of June 2022. Obstetric history. Present obstetric history. Her LMP was 12th of June. Her EDD is 19th of March. Her period of gestation by date is 32 weeks, 2 days. She is gravida 2, para 1, live 1, abortion 0. Spontaneous conception with no antenatal visits in past for current pregnancy. There was no history of iron and folic acid tablet intake. She has received 1 dose of tetanus toxoid at 5 months of gestation. Past obstetric history. Last childbirth was 1.5 years back when she delivered an alive preterm male baby at 34 weeks of gestation, weighing about 2.1 kg at District Hospital, Agra. Child cried immediately after birth, was breastfed, and is completely immunized. There was no history of bleeding, any intervention in last pregnancy, and her postpartum period was uneventful. Past history. No major medical problems like hypertension, diabetes mellitus, tuberculosis, asthma, thyroid disorders, etc. No significant surgical and gynecological past history. Family history. No history of diabetes, hypertension, asthma, TB, blood dyscrasias, or known hereditary disease in the family. Personal history. Dietary history, she was vegetarian. Her calorie required was 2,500 kilocalories. Her calorie intake is 2,100 kilocalories. Protein intake is adequate. Her calorie deficit being 18%. Allergy and addiction history, no history of any substance abuse, smoking, alcohol intake, or high-risk behavior. Functional history, her appetite was normal, bowel and bladder habits being regular, her sleep-wake cycles were normal. Drug history, no history of any drug or contraceptives intake.
General physical examination. Patient is conscious, cooperative, and well-oriented to time, place, and person. Patient is a thin-built and poorly nourished. Her vitals are: pulse rate was 82 beats per minute, blood pressure was 120/74, respiratory rate was 16 breaths per minute, mild pallor present, there was no icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Her height was 154 centimeters, weight was 52 kgs, so BMI was 19.92 kg per meter square. Orodental hygiene was well maintained and no signs of nutritional deficiencies seen. No dilated veins over the neck seen. Thyroid appears to be normal. Breasts bilaterally symmetrical, slightly enlarged in size, with nipples not retracted. Montgomery tubercles was seen, and no palpable lump. Systemic examination, central nervous system, cardiovascular system, and respiratory examination. Inspection, skin was normal, abdominal style gravidarum seen, no dilated veins or visual pulsation seen, no visual scar marks seen, hernial sites are free, all quadrants moving equally with respiration. Palpation, abdomen was soft and non-tender. Fundal height corresponds to 32 weeks of gestation. Symphysia fundal height measuring 32 centimeters. Abdominal gut was 32 inches. Uterine contractions are present, coming at regular interval of 20 minutes, and each contraction lasting for 15 seconds. Grips on fundal palpation, broad, soft, irregular mass felt, suggestive of breach. On lateral palpation, multiple small irregular knob-like structures suggestive of limbs felt on the right side and smooth curved contour. First pelvic grip, hard, globular belatable structure felt suggestive of head. Position of head 5 by 5. On auscultation, in the middle of left spino-umbilical line, fetal heart sound was auscultated and was 150 beats per minute and was regular. Local examination, external genitalia appears to be normal. For speculum examination, vaginal mucosa seems healthy. Cervix was centered in position, show present. There was no leaking per vaginal. For vaginal examination, cervix is 2 cm dilated, 60% effaced, center in position, soft in consistency, membrane present, head at -2 station, show present, and pelvis is educated. Summary: 29 years, gravidity 2, para 1, live 1, abortion 0. At 32 weeks gestation, presented with chief complaint of pain in lower abdomen for 8 hours. Pain is dull in nature, coming at half-hourly interval, associated with tightening of the abdomen. There are no relieving and aggravating factors. On her abdominal examination, single live fetus with longitudinal lie and fundal head corresponding to 32 weeks of gestation. Adequate lical, fetal heart rate is 150 beats per minute with return contractions at regular interval of 20 minutes, each lasting for 15 seconds. On per vaginal examination, cervix is 2 cm dilated and 60% effaced. Membranes present and there is no leaking per vaginal. So the provisional diagnosis was a 29 years gravidity 2, para 1, live 1, abortion 0, 32 weeks, 2 days of pregnancy with past history of preterm labor in preterm labor. And
Thank you very much, Ayushi and Priyanka. I think that you have done reasonably well. Now, I would like to go back to the first slide of your presentation to have some few questions crossings. We'll come back to the summary and presentation later on. Go back to the first slide, please. Yes. So this is the patient particulars, which you have written well. Resident of Loha Mandi, Agra, which is not very important, but important is the distance from your hospital, which this patient has to travel to avail the obstetric services. Okay, registration number, date of admission, etc. Oh, okay. Now, next slide, please. You haven't written the broad heading, that is chief complaints. Chief complaint is pain in the lower abdomen for last 8 hours, along with amenorrhea for 8 months. Next slide, please. Make it next slide.
Next slide, Priyanka.
yes,
Yeah. Keep it on the next slide, please. Previous slide.
Previous slide. Previous slide. Chief complaints. Come to chief complaint.
Yes.
Yeah.
Now, this contains another additional statement. This was her first antenatal visit, which you don't write in chief complaints, right? It is a very significant, important finding, but you can move it somewhere else when you go to the present pregnancy history. Do you agree? First antenatal visit is not a chief complaint. So our chief complaint is only one, that is lower pain in the lower abdomen for last 8 hours, along with the amenorrhea for 8 months. Full stop. Okay. So delete this sentence. This was her first antenatal visit. We'll go to another heading. Come to the next slide. History of present illness. You have written very well. Next slide. Yes. Pain, you have described the pain in the lower abdomen, and all students to hear that this history of present illness is different from history of present pregnancy. Here she is describing the pain abdomen. This pain abdomen has to be elaborated. The aggravation, the relieving factors, the onset, okay, associated with some other findings, etc., etc. So this is quite well written. Next slide, please. And the associated findings are also written well here. Next slide, please. Yeah. Now the history of present pregnancy is different because it is associated with the pregnancy. Now, first and second trimester are uneventful, and there was history of lower abdominal pain and lower back pain and blood-stained vaginal discharge in the third trimester. Okay. So that happened later on in the third trimester. Menstrual history. Next slide, please. The most important finding is the cycle, the regular cycle she had, and this LMP, whether she was absolutely clear and normal and confident about her LMP or not. Next slide, please. In the obstetric history, present obstetric history, what are the points she has written? Our LMP, you should not start with the LMP. You start with the present obstetric history is whether she was antenatally cared or not. So antenatal care, regular, irregular, nil. This is the way you should write. The number of antenatal visits. And it was surprising to hear that there is no antenatal visits in the past for current pregnancy, in spite of the fact that she had a history of preterm labor, right? Okay, so this is a very, very important information. And also significant finding is that there is no history of iron and folic acid tablet intake in this pregnancy. So on 2 accounts, she has missed out our advice maybe, or she didn't come to the hospital for the antenatal checkup. Okay. She has received 1 dose of tetanus toxoid. She should have received 2 doses by now. And the past obstetric history, always you should write in the box pattern. Okay. You know, the boxes are available in all textbooks. And the last childbirth was significant by the birth of a preterm baby, 2.1 kg at a district hospital in Agra. I don't know how far it was from your hospital. The child cried immediately after birth. There is no history of admission into SNCU or NICU in this baby. So therefore, we will assume that the baby is live, well immunized and breastfed. There was no history of bleeding, any intervention in the last pregnancy, and her postpartum period was uneventful. So that is about the present and past obstetric history. And I believe that you have written well, except that the present obstetric history, I think you should highlight these 2 things, that she had no antenatal visits in past in the current pregnancy, and also she didn't have IFA prophylaxis and calcium, etc. The next slide, please go on changing the next slides fast, because these slides do not contain any important information. Family history, because they're all unremarkable. The dietary history, I just wanted to highlight here that the dietary history you take in a lot of detail and thereby wasting a lot of time, I think. This is not necessary in our country, because neither this quantitative estimation of the diet or quantitative, determination of the diet is useful, nor is it, worth remembering, because the patients hardly remember it. And you don't have any record of these dietary intakes, etc., the calorie intake, etc. So what we do is an approximation. So you need to ask some gross questions to the patient and take out the dietary history. This much of calorie deficit and protein intake, calorie intake, etc., is not that necessary. In the personal history, you should add allergy, addiction. Okay, that's okay. Functional history is okay, and drug history is also okay. In the general, next slide, please. In the general examination, I think the most significant, what is the most significant finding in the general examination? Can you tell us? What is the most significant finding in this general examination?
Answer has come.
Answer has come, yes. Okay, the most significant finding is the BMI. Okay, do you think the BMI is normal here? Surprisingly, her pallor is only mild, in spite of the fact that she didn't have any iron supplementation during this pregnancy. What may be the reason for this? Ayushi.
So please, can you repeat the question?
She has only mild pallor, right? And the history sheet you have written that she hasn't taken any iron and folic acid supplementation during the entire pregnancy, right? So what may be the reason?
So she was taking adequate diet. Through diet, she has supplemented.
Okay. Do you think the dietary iron is enough?
No, sir, it is not. No, sir, it is not enough. In pregnancy, iron supplementation is needed.
So pregnancy iron supplementation is mandatory, right? Okay. What is the daily iron requirement during pregnancy? First, second, and third trimester. You can say separately. Ayushi or Priyanka, anyone can say. It's a very important question. They are frequently asked in examination. Okay. So the iron requirement in the first trimester is very low, something like 1 to 2 milligram iron per day. In the second trimester, it keeps on rising from 3 to 4 milligram per day. But in the third trimester, it increases to 6 to 7 milligram per day. Maximum iron requirement in the third trimester, because the baby is growing actively. Okay. So that is why And as because our country is iron deficient, that is why WHO has recommended obligatory iron supplementation in all patients, irrespective of the category of the patient, irrespective of the socioeconomic status, irrespective of her nutritional level or how much good or bad she may be in iron intake, iron supplementation is mandatory. WHO has clearly stated that any country whose prevalence of iron deficiency anemia in the pregnant population is more than equal to 40% must take iron supplementation during pregnancy. Okay, so that she's not having, but she's still having only mild pallor. What was the reason behind this? Could you explain this?
Pardon, sir.
One of the reasons you said that she was having a good amount of iron in the diet. But that cannot explain everything. So the lady must be having enough iron store in her, isn't it? That may be the only solution, but it looks something like, not very believable thing. So mild pallor, it's questionable, because we'll now go back to the, investigation part to answer this question. Okay, when you do the investigation. Okay, fine. So BMI is low, justifiably so, and she's having nutritional deficiency. That is clear cut. So do you get any clue from this about the diagnosis of anemia? Okay, next slide, please. This looks okay to me. Orodental hygiene and well maintained, and no signs of nutritional deficiencies you didn't find. And then no dilated veins, thyroid appears normal, breasts are normal, examination is normal. Okay, next slide, please. Systemic examination is unremarkable. Okay, next slide, please. Abdominal examination, inspection, you have written well, no problem about that. Then palpation, the usual stuff. Next slide. Palpation, the usual stuff, abdomen soft and non-tender. Fundal height corresponds to 32 weeks of gestation. Symphysis of fundal height measuring 32 centimeter. Abdominal girth at the level of umbilicus, you should write, that was 32 inches. Uterine contractions are present, coming at regular interval of 20 minutes, and each contraction lasting for 15 seconds. Okay, so the contraction duration and intensity is important. Next slide, please. Grips are all okay. We have written grips well. The fundal, the lateral, the first pelvic, and the second pelvic grip. The position of head, this is the Crichton's maneuver to see the engagement of the head. So you should write that for the engagement of the head, this is the maneuver, that is 5 by 5. That means the head is absolutely floating, right? Can you tell me at what level does the engagement of the head occurs? You have written this 5 by 5. That means head is floating. At what level does engagement occur? Ayushi? Pooja has answered this 2 by 5. Do you agree? Well, engagement happens between 2 by 5 and 3 by 5. And it happens silently. Okay. No one knows. Usually at dead of night, the engagement occurs. In real life, also engagement happens without the knowledge of the parents, isn't it? So this engagement of the head occurs at between 2 by 5 and 3 by 5. Okay. In auscultation is also okay. Next slide, please. And there is this. What is the significant point in this slide?
There is no leaking.
There is no leaking. So it's a preterm labor, but it is not a case of preterm rupture of membrane, premature rupture of membrane or preterm rupture of membrane. It is not that. And it should be PPROM. The terminology is PPROM. What is the difference between PROM and PPROM?
The PROM is premature pre-labor rupture of membranes. That is spontaneous rupture of membranes without the onset of uterine contractions, where the PPROM is before the 37 completed weeks.
So the component of PROM is added by the preterm pregnancy, isn't it? That is called PPROM. Okay. So what is this case? This is a PROM or PPROM? If there was leaking, then what would it have been? PROM or PPROM? In this case?
PPROM.
Should be PPROM. Next slide, please. In pervaginal examination, you find the cervix is already dilated, 60% effaced. Okay. And cervical consistency is soft, position is central. So what do you see at this, what do you say at this PV finding? What do you have to say? Is the patient in labor?
Yes, the patient is in early labor.
Patient is in early labor, that's right. Okay. So come to the next slide. Now this is the slide which is most important slide of the entire presentation, because when the examiner comes to you and she or he asks you, what is your case? This is what you have to tell him or her. Okay. And it is always better to start with the patient's name. Why name is important? You can abbreviate the name, you can camouflage the name, you can keep it partially, confidential, but the name is important. Why? In the presentation?
To identify the patient.
Identification is one point, yes, okay.
Patient-doctor relationship establishes when we...
Pooja has replied, religion, I'm afraid that's not the case. You do not expect a religion to be identified from the names. It is not ethical also, not good also. So what is the reason why we want the name in the short form? Because it identifies or signifies the association between the doctor and the patient, isn't it? Remember, this patient is admitted under you. It will not be good to call her like a PROM patient or preterm labor patient, like we call the chai wala, badam wala, etc., something like that. So it is always better to call her by name. Okay. So Mrs. Swanso, 29 years, gravida 2, para 1, living 1, abortion 0, at 32 weeks of gestation, presented with chief complaint of pain in the lower abdomen for 8 hours. This is your first line. I would have suggested a slightly changed version, like Mrs. Swanso, 29 years, gravida 2, para 1, living 1, abortion 0, carrying 32 weeks of pregnancy, and staying approximately 4 kilometers away from this hospital, belonging to an average socioeconomic status family, presented to our OPD or emergency with the complaint of low abdomen, pain lower abdomen of 8 hours duration at dead of night or in the daytime. So this is the way you bring the patient first to the admitting hospital. So all the information are there. You have given information about the gravida, para, etc., her age, okay, her socioeconomic status, her presenting complaint, how far she stays away from the hospital, and how much time she can take to come to the hospital, that also you can assess. And the complaint. The complaint was pain lower abdomen for 8 hours. Then you have described the pain. Pain is dull-aching in nature, coming at half-hourly intervals, associated with tightening of the abdomen. There were no relieving and aggravating factors. What else is missing here in this summary, in this line? Would you like to add something? A very important information which is being omitted from the summary? Can anybody tell me? Sohini or Priyanka? One vital information is missing here. Yes, there are suggestions that the general examination findings are missing. That's true. Somebody said...
Previous history of preterm labor.
Yes, that's the most important thing that is missing in this summary. Remember, whenever we teach preterm labor, the most important aggravating factor or precipitating factor for preterm labor is the previous history of preterm labor. And one you have got, if you omit that, that is not a good summary, I must tell you. Examiner will not be happy. Because she's listening to you. She's, while going through the history sheet, she's reading all these things that you have written over there about the previous history of preterm labor, haven't mentioned in the summary. So prepare your summary well. In her last pregnancy, she also had...
Sir, can I add something more here?
Dr. Ashok Kumar, yes.
See, that is why we always insist, and if you see our previous program also, we insist, and in your textbook also, like when we write this abbreviation, you've written 29 years G2, P1, L1, A0. Now we are putting in four
digit,
parts, 4 digit. So
yeah.
if we make that as a standard,
Yeah.
So we will be able to pinpoint there also that one of the component is about the preterm deliveries. So
Yeah.
that we can do, right?
That is also.
So I think we request all the students to follow that 4-digit pattern while presenting. So that will help in understanding also. So
Correct,
before we proceed further in the summary, can we go back to a previous slide?
Yes, sir.
And I would like to have the comments from the teachers also there. Just go back to the previous slide.
Go to the previous slide. For vaginal examination, you want, no?
Yeah, that examination finding, yes.
Yes. Go back to the previous slide, Chika. Sorry, Ayushi.
Okay, if it is not possible, then we can leave it.
No, it is possible. Why not?
Go down, go down.
Yes,
Yes.
yes.
And one more slide, just go back. Yeah. See, once we have per speculum and per vaginal finding in this patient, I would just like to know that why PV was performed. Are we sufficient to gather the information on speculum examination? In this case of preterm labor, where we are suspecting preterm labor. So that is the question we want to know, and I want the student to respond, and then we can discuss, and our teachers can also give their opinion and
Sir, I couldn't follow your question. What was the question?
My question is, we have the information on speculum examination. Is it mandatory to do PB in these cases?
Okay. Students, can you answer this? Ayushi or Priyanka, can you answer this? It's a very important question. Pooja has already said it's not mandatory. What is your opinion? And there was also comment that she was having contractions. Remember her presenting complaint was pain abdomen. So I think that after the speculum examination is also mandatory, my opinion will be that you should also do a PV examination because she has been always complaining of pain and for last 8 hours.
Here I want to discuss.
Yes, Sela, you wanted to say something before Dr. Ashok?
Yes. In perspiculum examination, they could have mentioned about cervical dilatation, whether it was visible or not. So there was no leaking, that's fine. And then if dilatation was visible, they could have directly went ahead with PV examination.
Okay.
No,
So,
sir, yes, madam, Doctor. Yes, madam.
Ma'am, sir, in PS examination, after seeing the show is present, before doing the PV or confirming the cervical dilatation, always take the swab for culture and sensitivity.
Correct,
Then put
correct.
the finger inside.
Yeah.
Sir, I want to put the other side of the story also.
Yes, sir.
Because students should know,
Yes, sir.
students should know both the points. See, usually in preterm labor, we avoid PV examination if patient is in early preterm labor, because multiple PV examination will obviously lead to infection. So that is the point to avoid. But here the speculum examination finding should have been in detail. We should be able to know the dilatation in the cervix, and we should be able to mention the length of the cervix also on PS examination. If we feel that it is early, it means the os is not open, or it is 1 centimeter, or there is still length of the cervix, then we can avoid PV even in the presence of uterine contraction, because then it establishes that probably patient is in early labor. So this patient, the labor pain may stop also with our management. So it is better to avoid repeated, because PV is a source of infection. So that is the only thing. The other point of view who advocate that PV should not be done, that is their view. But once the patient is in labor, I will say if you feel on PS examination, if it is indicated, then definitely you should proceed for PV examination. Otherwise, you can stop short of PV examination if patient is in early preterm labor. That is the other side of the story. The people who advocate not to do PV.
I take your point here, and Dr. Ashok Kumar, I'll just have one or two points being added. The students must know that in most of the cases, when you put in the speculum, you must put a good big speculum, casco
Yes.
speculum, and it is a telltale finding. If it is so, and there is no leaking, cervix is effaced. Cervix efface can be easily made out by a speculum only, and there is no leaking, then I will rather go for a gentle digital examination just to see the palpate the cervix and whether it is soft or not. Now, there are certain cases where you need not do so, and particularly when there is leaking, you should not do so. So when there is leaking, you avoid the PV examination blanketly. But when there is no leaking and there is doubt about the effacement of the cervix, the length of the cervix, etc., there is doubt, and the patient is not.
Yes, sir.
And then to diagnose threatened preterm labor, because now we can go for tocolysis. Those are the cases where I will prefer a gentle digital examination by an experienced obstetrician, not by a trainee. Okay, this is very important to, number one, to see the Bishop score if she's in labor, and number two, if you want to give progesterone or if you want to give tocolytics for this particular case. So I will prefer always, I don't know, it may be a mental block in most of us that you feel like feeling the cervix. The soft feeling of the cervix goes more in favor of the established preterm labor, where the tocolytics and progesterone are inversely effective. So I will not go for that. That is my opinion.
Okay, now, sir, we start with the management.
Yeah, now we'll go to the summary part. And I have over one or two more important points to mention.
Yes, sir. Yes.
As I said, go to the summary slide, please. Ayushi, go to the summary slide. Yes, Ayushi, stick there. Okay. As I said, there is an important information missing over here. That is the history of preterm labor in the past pregnancy. It is mandatory to write it over here. Otherwise, your marks will be deducted. I'm telling you. Okay. In this pregnancy, you have written well, but you must highlight one or two important findings. That this pregnancy, she did not receive antenatal care. She did not receive IFA prophylaxis. So these are all very important findings to be written in summary. So I will prepare a good summary and I will send you and keeping in all information. Remember this, you are telling the examiner who doesn't know anything about this case. So if you miss this vital information, examiner in all probability will not be able to make a provisional diagnosis. And this thing will be, damage will come to you. Okay. Also, you see the general examination findings are missing over here. Systemic examination, just one line. In general examination, you can write, you can comment that in spite of having gross nutritional deficiency, low BMI, and this no iron supplementation, she's having only mild pallor. This is an important finding. If you don't make these comments, then the examiner will as it is automatically find out from the sheet, and then he will question you. You will not create a very good impression. So my opinion is that you just write a fresh summary. Summary should be a bit longer, mentioning important findings, important positive findings, excluding negative findings. And then the general examination, what you have to write, that I have already mentioned, and Dr. Ashok Kumar has detailed discussion. So there is some distinct difference of opinion about the digital examination of the cervix. And some people do it, some people may not do it. There are two schools of thought. Both are justified, but once you say something in the examination, you must justify your opinion. Okay, so go to the next slide, please. I'm sure you're coming to the provisional diagnosis. Yes, 29 years, G2, P1, L0, but change it to, as Dr. Ashok Kumar said, G2 plus, G plus, four pluses. You write like that. Then 32 weeks, 2 days of pregnancy with past history of preterm labor in preterm labor. Okay, you have written past history of preterm labor in the diagnosis, but you haven't written in the summary. Okay, in preterm labor. Okay, so with that, now we will start the discussion. I will invite the other faculty members to kindly ask questions.
So, okay, Priyanka, wouldn't it have been better if you would have written threatened preterm labor, or what? It would have added. So first tell us, what is the difference between threatened preterm labor and established preterm labor?
In threatened preterm labor, there are documented uterine contraction, but there is no evidence of cervical changes. Where in established preterm labor, cervical dilatation is more than 4 centimeters.
So what are the exact cervical changes?
With uterine contractions.
Cervical changes?
Ma'am, cervical changes in preterm labor, cervical dilatation should be more than 2 centimeters. Cervical length, it should be less than 2.5 centimeters. And cervical effacement should be more than or equals to 80%. And Bishop score should be more than 4. And uterine contractions, they should be, ma'am, either more than 1/10, or it should be more than 4 contractions per hour.
Okay. So other faculty may kindly proceed.
Priyanka, what are the risk factor for preterm labor and what are the risk factor present in your case?
Risk factors for preterm labor are multifactorial. First of all, social economic status. Low social economic status predisposes to preterm labor, and undernutrition, underweight. Our patient has low BMI, which is also a risk factor for preterm labor. Advanced maternal age, decreased inter-pregnancy interval, lower genital tract infection, urinary tract infections, systemic infections, past history of preterm labor, which are present in our case, is a strong risk factor for preterm labor. And there are congenital anomalies of uterus, cervical incompetency. In many cases, preterm labor is idiopathic also, and maternal systemic diseases like preeclampsia, gestational diabetes, measure they are elective preterm labor, preterm births.
What do you mean by decreased interval between the pregnancy? How much? You said one of the risk factors is decreased interval between 2 pregnancies.
Yes.
Ma'am, progressively, if there is decrease in the interval between the 2 pregnancies, the risk of preterm labor increases.
Okay. And what are the factors present in your case?
Ma'am, firstly, the patient is thin built and she's poorly nourished. Then she belonged to a poor socioeconomic area where, and also she has the history of previous preterm delivery.
That's most important. That is most important factor, history of preterm
Previous
delivery.
preterm.
So if you're asked in the exam, what are the important risk factors in this case? You say this in order, as Dr. Urvashi has said, that is the first most important predisposing factor is the history of preterm labor. That is the most important. But what will come at the second? Who said that? What is the second?
BMI.
Low BMI.
Physical examination is thin built,
Okay.
poorly nourished.
What will come as third? You should be prepared with 3 answers. Okay, at least.
Low interpregnancy, short interpregnancy interval.
No, see, apply logics to your answer. See, the low BMI could be for various reasons. There could be some other reasons. But here, the most important factor is nutritional deficiency, anemia, and there is no IFA prophylaxis. You have to say all these things, no? And then comes the, the low interpregnancy intervals, etc., etc. So prepare your answer according to the importance and the way they appear, the way they affect the pregnancy. That is the way you should answer. Okay. Yes, go ahead, Urvashi.
How will you proceed for your case? How you will manage this case?
Ma'am, yes, ma'am. Ma'am, as we could see, our patient, she is in early preterm labor. So we will manage it conservatively. As a patient is 32, her gestation is 32 weeks. So, and uterine contractions are also present. So we will prefer the tocolytic agent here. And preferably what
management means first you say the investigation and then the treatment part.
Correct, absolutely correct. So the student should understand the importance of these questions. Whenever they ask a question like management, don't jump for the treatment, drug treatment, surgical treatment, etc., etc. Always ask yourself, are you sure about this diagnosis of this patient? Is it a case of threatened preterm labor or established preterm labor? How many contractions are there? The contraction pattern that you have shown in this case is 15 seconds duration. It is not 40 seconds duration. Is there a scope of reverting this or preventing preterm labor? You must ask these questions. And for that, you need some investigations. So your management also demands some investigation. And that investigation may start from history also. Okay. So remember, these questions are very, very important questions that actually, if you answer like that you will go for tocolytics or you can go for management of labor. That's a brainless answer. So you have to consolidate within yourself. You are going to become a consultant, right? And then you have to find out whether this patient is suffering from established preterm labor or threatened preterm labor. And to diagnose that, you need some investigations. And also to support her nutritional status and anemia and other things, you need some investigations. And then only you can go for the management. Yes, continue.
What all investigations you will undergo?
And we first get her routine complete blood count done and urine complete routine microscopy culture. And then we can do high vaginal swab also, and we will go for ultrasonography for the estimation of gestational age, like fetal weight, line presentation.
Wait, one by one. You have said complete blood count, CBC. What information would you like to gather from the complete blood count?
We can see that whether the patient is anemic or not, whether the leukocyte is present or not, we can.
Good. How to diagnose this anemia, or what are the important findings and suggestive of anemia? What findings will you get in CBC, complete blood count, suggestive of anemia? What is the degree of anemia, type of anemia? Can you find out from the CBC? From the complete blood count, can you find out? What are the findings in complete blood count?
Components of CBC.
Diagnose anemia from CBC.
Yes.
In simple way.
Yes, beta. Did you ask something?
How you diagnose anemia from CBC that Dr. Ashish is asking? What are the value? Hemoglobin, MCV, go on.
MCHC.
So today's PGs must know this very clearly. Complete blood count is a very important investigation today, which the obstetricians have been ignoring this over a long period of time. But complete blood count suggests a lot of things today's examination. And today complete blood count is also easier to get. You get in 15 minutes time. Okay. So the first thing is, if you please put it down, writing hemoglobin percent is the first. Okay. But unfortunately, there is a late diagnosis of anemia. We diagnose anemia much earlier than hemoglobin percent these days. What are those findings? The first one is so that is degree of anemia and the type of anemia. How do you diagnose type of anemia?
We will, by the smear, we can diagnose the type of anemia. We found microcytic hyperchromic RBCs with anisocytosis that is indicative of iron deficiency anemia. And by hemoglobin, we can.
We are asking not from general blood picture. We are asking from the CBC report only.
CBC report.
Okay.
Yes. No, the peripheral blood smear is included in the CBC. So they are right to say that.
It comes very early. As the patient comes, the report comes early. You just see MCV, MCHC, and
the first
RDW.
What Dr. Urvashi is saying is the hematological indices. You must know the hematological indices. What are the 4 hematological indices to diagnose anemia? Very important question.
Sir, MCV, MCH, MCHC, and RDW.
Okay. So MCV, how much do you expect? You said
normal range is 75 to 96
okay.
femtoliters.
What is the lower side? What is microcytosis?
So less than 75.
Less than 70. Less than 70 is microcytic.
Okay. So
Then
that's about the micro. What else? What is MCH and MCH?
MCH, the normal range is 27 to 33 picograms.
Okay. And what is RDW? What do you expect from RDW?
Red cell distribution.
So red cell distribution width.
How much will it be? And how do you differentiate it from other forms of anemia with RDW? See, you must know all these things in detail because anemia is very common in our country. And as per last NSHM data, it is more than 50% of our pregnant women are suffering from anemia. So you must know anemia in detail. So the RDW will be a higher side. That means the red cell are sparsely distributed. That means the red cell distribution width is higher. It is suggestive of iron deficiency anemia. Okay, because from the same finding, you can also have some diagnosis or some clue about thalassemia. Okay, that's very important to know. So that is about the complete blood count and also the peripheral blood smear that you have said. Anything else that you want to diagnose from any other investigations? Anemia.
and even in complete blood count in preterm labor, you have to see the total count because one of the important causes is infection.
Yes.
Preterm labor.
They have said neutrophil leukocytosis. They have said how much is the leukocytosis usually? Because remember, in pregnancy, always there is some degree of leukocytosis, right? So need to analyze that report very carefully.
What is the normal level of TLC in pregnancy and what is the normal level during lactation? So basic question.
Normal level is from 4,300 to 10,000.
In pregnancy.
No, in normal, in general.
So madam has asked about pregnancy and lactation.
Okay, I think we cannot.
Student can give the answer. This is a very important and simple question.
Mhm.
Any student can give the answer.
Yeah. Is it increased or decreased?
Yes, 4,000 to 15,000 somebody has given. Anchal, okay. And during lactation? Can go up to 18,000. Okay. We have to rule out cause of infection also from CPC.
Okay. So these are very important things and you must read in detail all these things. Okay. So any other investigation for anemia you suggest in this case?
Very important in our country.
Pooja has suggested ferritin, which unfortunately is not true. It is not a diagnostic method of anemia. It is for the follow-up of the treatment. We'll come to that later on. But as Urvashi has said, a very important investigation. Electrophoresis, Dr. Noor has suggested. Unfortunately, this is also not routine during pregnancy to diagnose unless and until you have a strong suspicion index or of thalassemia, and also you have the suggestive finding from the RDW. Peripheral smear already discussed. So anything else?
Somebody has written a stool examination.
Yes. Stool and urine examination. The students frequently forget. Okay. Remember, urine examination is very, very, very important, and so is the stool examination. These two exams are being neglected in the modern obstetric practice, but they are very important information they give. Okay. So that is about the investigation. Anything else you want to add? You are talking about ultrasonography. Justify your ultrasonography. When will you do it? At what gestational age? And what information you would like to get from that ultrasound?
You were already talking about this. Just repeat it.
Okay. Ma'am, through ultrasound, we will get to know about the lie of the fetus, then the viability of the fetus, gestational age, then about the status of the liquor, whether it is oligo or poly, and whether there is any fetal anomaly or not, that also we could rule out.
Come down.
The placenta localization of
Okay.
और कुछ most
placenta.
important things मैंने hint भी दे दिए.
Come down. Ayushi, please come down.
No.
Cervical length.
Cervical length is twice here. Length of the cervix. Is it important?
Yes, sir, it is
Yes, sir.
important.
How do you measure cervical length? Trans-abdominal ultrasound?
Transvaginal. So
Trans-
transvaginally.
Okay. What is the critical length of cervix?
So 2.5 centimeters.
Yeah, has
If it is
answered
less
that.
than 2. Sorry, sir.
0.5 centimeter. Okay. So why is it
And
important? Why do we see the cervical length?
So routinely in all the cases, we do not see the cervical length. But in cases of suspected preterm labor, the patients who have the history of previous preterm delivery, we generally assess the cervical length at 16 to 24 weeks of gestation.
For what purpose? What do you like to do with that patient with a history of preterm labor and cervical length hovering around between, say, 2 centimeter to 2.5 centimeter? What do you do with these patients?
So we do the cervical cerclage in these patients. So in order to prolong the duration of pregnancy so that the patient doesn't end up in early preterm labor.
Anything else?
Which is suggested recently by very important in reports, good amount of evidence just come up.
some hormone.
Somebody has written cerclage, this thing. Do you go for cerclage in this patient, the patient who is having pain abdomen, and then you have to assess your still plus minus whether you were in active preterm labor or not. Do you go for cervical cerclage in this case?
No, sir.
Okay, fine. So, and there's another 2 things important. One is, I'll tell you, one is progesterone, evidence in favor of which is coming up very strongly. And 2 is the contraction prevention. Would you like to go for that?
Tocolysis.
Tocolysis, yes.
Yes, sir, we will use the tocolytic here.
Which tocolytic will you use?
So
Before
Nicardia,
starting
calcium
the
channel
delivery.
blocker, nifedipine we will be using here.
You're not listening to the
One second.
suggestions.
Before
Somebody has
starting
written-
the tocolysis, do you want to see any test? Your patient is unbooked. Do you want to see something else in blood? Blood sugar level? Your patient is unbooked patient. You should see blood sugar before starting the tocolysis.
Okay, ma'am.
And
And we will
comment-
also monitor the
Any-
vitals, like we will look for her pulse rate, temperature. Like for Nicardia, side effect like mostly causes tachycardia. So if the patient is tachycardic or his pulse is more than 100, we will try to avoid Nicardia and use the other tocolytic agent.
Priyanka, we avoid using brand names. So it can be a simple calcium channel blocker, nifedipine or what.
Nifedipine.
Okay. So
So
you have
what
said
dose-
about the
Comment on
contraindication
fetal
of
fibronectin before starting the tocolysis. Do you want to see the level of fetal fibronectin in cervicovaginal discharge? Any comment?
Ma'am, it is not routinely done. Fetal fibro in our hospital, we do not routinely do this like fetal fibronectin in the cervicovaginal discharge.
which
But what is the
tocolysis do you
recommendation?
use in routinely in your hospital? If you use,
So we preferably will use calcium channel blocker.
okay, provided there is no contraindication. Yes, of course.
In what dose you are giving?
So, firstly, we give the loading dose of 20 to 30 milligram, 20 30 milligram nifedipine, followed by 10 milligram 6 hourly for 24 hours, and we will monitor her pulse rate. And this 24 hours, yes, ma'am, till 24 hours we use this till the contraction subsides.
Okay, we are gradually moving to the critical time of 12:30 p.m. We need to wind up very fast. Would you like to give magnesium sulfate and steroid, if necessary, at which dosage? She's carrying 32 weeks.
So we will prefer the steroid. We will give the steroids in our case. We will prefer the dexamethasone here, sir.
What is the dosage schedule of dexamethasone?
Sir, it is given in 4 doses, 6 milligram, 12 hourly, 4 doses for 48 hours. Intramuscular injection.
Okay. There is a comment in the box that is no magnesium sulfate with calcium channel blockers. Unfortunately, that's not true. You can give it, but you have to be careful. That's the
Yes.
answer. You can give. There is no problem about giving it, but you should be careful.
But we have to stop the
So
token.
magnesium sulfate, how do you give? Muskan, thank you very much. Magnesium sulfate is the what regime do we follow in this case for neuroprotection?
Loading dose of 4 gram IV over 20 to 30 minutes. Thereafter, maintain dose 1 gram per
IV
hour.
infusion
For
How do you give
24
it? 1 gram per hour,
for 24 hours.
24 hours. Okay. So that is about the magnesium. Would you give antibiotic to this patient? Quick. If yes, which
Sir,
antibiotic?
we can give, but there is no proof. Yes, sir, we can give the antibiotics here, but there is no proven role of antibiotics.
in case of
Like,
intact membranes.
See, there is a difference of opinion, just like that other thing that we were discussing.
Yes,
There is
sir.
some role of the antibiotic according to some, because many of the infections we cannot diagnose by culturing. Simply by
Yes, sir.
looking for antibiotic, we need to think about that. And if necessary, what antibiotic will you give?
What we are using in labor daily?
So we are using metronidazole and cefotriaxone.
Not the simple ampicillin? Ampicillin and clindamycin are recommendation for preterm.
Ampicillin and gentamicin has been suggested in the box. Would you like to take that? They're available freely in your hospital. Like to go for that? Metronidazole is of course important for bacterial vaginosis and other infections. So ampicillin, gentamicin, clindamycin, these three are important things. What about cephalosporins and what about erythromycin? Erythromycin you can give?
The azithromycin we can use for bacterial vaginosis if we are suspecting any bacterial vaginosis infection.
Okay. What about coamoxiclav? Would you like to give it?
Moxiclav we do not give because it causes necrotizing enterocolitis.
Okay. Now come out of this and tell me how frequently or infrequently you do the PV examination to see whether the patient is progressing into active labor. You have to do that, right? Do you do a partograph?
Yes.
Partograph you start. What is the modern guideline about?
No, sir, no,
partograph?
percentage.
Now from here, the examiner can go to CTG, labor care guideline, etc. Everything. I'm not going there because the time is limited. So you tell me whether you do partograph or not in this.
No,
case.
sir.
No, sir.
No, sir. Okay. As it is a relief for you because most of you don't like to do a partograph. I know that. Okay. So now suppose the patient has gone into unestablished labor case. Okay. From certain preterm labor, she has gone into frank preterm labor. How do you manage this case? Quickly. In 2 minutes, we will just wind up because we have to have the next case.
The patient has passed into established labor. Then we will first plot partogram and we assess the progress of labor. And the most important thing is to confirm the presentation of the fetus.
अभी तक नहीं किया अच्छा okay fine. So you continue the tocolytic or not? The same tocolytic comes back over here.
No, sir, we will not continue the tocolytics.
So what is the modern day concept about tocolysis? Previously, we used to give tocolysis for weeks or days, but nowadays it has been restricted. Sure. And because it is called, there are only 2 indications of giving tocolysis today. One is transfer to a higher center if your center is not equipped enough to handle a case of preterm labor, or maybe you do not have the supportive role by an SNCU or a NICU. That is the first thing. And second, to cover the
time for the steroid cover.
And these are two only indications of tocolysis nowadays. And this is called the emergency tocolysis. And there is no role of maintenance tocolysis these days. Although it has been trained that the progesterone that you have given, you haven't yet given progesterone, that has got some tocolytic effect over the next 13 years or so.
Okay, so may I ask 2 questions?
Yes, allow, yes.
Okay, so first tell me, you have delivered this baby. Would you like to go for early cord clamping or delayed cord clamping?
Ma'am, as this is preterm labor and we need the early resuscitation of the baby, we will prefer early cord clamping in this case.
And what are the problems of neonates which are born prematurely?
Respiratory distress syndrome, neonatal jaundice, neonatal septicemia can be there, hyperbilirubinemia. There are chances of birth asphyxia, cerebral palsy, and other neurological deficiencies.
Don't forget the metabolic disturbances like hypoglycemia, hypocalcemia, they're very, very important. Okay.
And retinopathy of prematurity.
Yes, ROP, yes.
So early cord clamping, just word about early cord clamping. If newborn is not requiring any resuscitation, then you can wait for 60 seconds, 30 to 60 seconds, right? Okay.
So that extra blood they receive.
So actually, a very quick assessment of the baby within 60 seconds of delivery is needed in order to see just whether the pediatrician needs to intervene in this case and send him or her to the special care unit. In absence of that indication, you can go for a 2-minute cord clamping. Otherwise, as you said, it's correct, 1-minute cord clamping is enough. What is the range of cord clamping timings in modern day practice, obstetric practice? That range has been
up to 3,
Sir, 30 seconds to 3 minutes.
1 to 3 minutes. Okay. So Stella, should we close it here now because we have another case?
Yes, yes.
Vashi.
Yes.
Dr. Ashok Kumar.
And, thanks both the students.
Yes, sir.
Dr. Ashok Kumar, anything else you want to add or subtract from this discussion?
No, sir, I think we have covered most of the thing.
Okay.
Only thing is, it is in the exam, it is a very tricky case when it
very
comes
tricky.
in the exam, preterm labor, because there are a lot of things to be discussed. And sometimes viva spill over to the PPRM also.
Correct,
So
absolutely.
it becomes 2 cases in a 1 case. So it is very important, and it is a theory question also very important for the student to understand the preterm labor management and everything. They should know risk factor and everything. They should know. This is very important topic for exam point of view. So we can start with the second case.
I think we should.
Yes. Purposefully, we have not put the term post-maturity or post-term pregnancy because the concept is changing, and in clinical practice also, everyone is looking for the expected date of delivery rather than post-datism or post-term. These terms are not used in the clinical practice. We are not putting the patient accordingly. We go by the weeks, exact period of gestation. It may be 37 weeks, 38 weeks, 39 weeks, 40 weeks, or 41 weeks. So let's discuss what to do when the pregnancy is beyond 40 weeks. We should start acting at expected date of delivery, or we have the time to wait, or we can go till 41 weeks, or we can go up to 42 weeks. So let's see how we are going to manage, and we are going to discuss this problem of pregnancy beyond expected date of delivery. So purposefully, this case has been put up to discuss the problems and the issues which are there. And Dr. Ashish will definitely agree with me that this is a really clinical problem. That as soon as we reach the expected date of delivery, we are talking of low risk patient. Basically, we should understand that we are not talking of any high risk patient. We are talking of low risk patient. There's no complication, uncomplicated patient, low risk patient in which. So these patients went to deliver. There's some evidence that they should be delivered at 39 weeks also. So there are studies and trial and recommendation also. So let's see how the case is presented, and we are going to discuss.
Dr. Ashok Kumar has put both the cases very, very thoughtfully and extremely good, important cases. They look apparently very, very innocuous. But I'm telling you, both the preterm labor as well as the this pregnancy beyond EDD, I would like to call it prolonged pregnancy. And these 2 cases are extremely tricky cases. and the examiner can go anywhere. So to do justice to this case, I think we'll call upon from Dr. Deen Dayal Upadhyaya Hospital, Dr. Ankur Pandey and Dr. Karishma Prajapat. I hope both of you are there, and Ankur should just share the slide in the presentation. Ankur, are you there? And the
Yes,
coordinating faculty is Dr. Shashilata Kabra. She's also there. I saw her just now.
Yeah. Good afternoon, everyone. I am Dr. Ankur Pandey, and I with Dr. Karishma
Ask
Prajapati.
Ankur to open his video.
Yeah.
Ankur,
Our
please
honored
open your
faculty
video.
also, I would like to invite Dr. J.M. Kannan here in this case as a faculty from Chennai, Dr. Apurva Kumar Bhattacharya from Assam, and Dr. Seema Grover from Punjab. Welcome, all of you.
Thank you. Thank you.
Good afternoon, everyone. I am Dr. Ankur from JDU Hospital, Delhi, and I with Dr. Karishma Prajapati under guidance of Dr. Shashilata Maheshwari ma'am. We are presenting a case of pregnancy beyond expected date of delivery. My patient is Mrs. Shilpa, 27 years old, female, wife of Mr. Narendra, resident of Uttam Nagar, New Delhi. She is housewife belonging to middle class.
Which year student to be unstable?
OPD with complaints of prolonged pregnancy.
Ashish has not said.
Yes,
Pardon,
madam.
pardon.
I think his
Pardon, ma'am?
video is unstable, so he can put it off if he wants.
Okay, ma'am. Fine, ma'am.
Fine.
So go from the beginning.
Yeah. My patient is Mrs. Shilpa, 27 years old, female, a wife of Mr. Narendra, resident of Uttam Nagar, New Delhi, housewife belonging to middle class, came to our OPD with complaints of prolonged pregnancy. Her date of admission was 8th
Please
of
go
May.
ahead with your question.
Yeah, sure. And thank you, ma'am. And her date of examination is 14th May. She is gravida 2, para 1, living 1. LMP is 30 July 22, and her EDD is 6th of May 23. Her period of gestation is 41 weeks plus 1 day. The chief complaints: the lady came for a regular checkup as her due date of delivery had already passed. History of present pregnancy: the first trimester history, regular ANCs was done. It was a natural conception and pregnancy was confirmed on UPT. She underwent all ANC investigations, which was normal as per patient. Ultrasound done was normal and corresponding. Weight gain in first trimester was approximately 1 kg. History of folic acid intake. No history of excessive nausea, vomiting. No history of fever with rashes. No history of exposure to radiation and drugs intake. No history of spotting or bleeding per vagina. No history of pain, abdomen, and no history of any increased frequency, urgency, burning, quickening at 5th month of gestation, and continue to perceive fetal movements well. Ultrasound was done to rule out any congenital anomaly and was told to be normal. 1 dose of DT was taken. Weight gain in second trimester was 3 kg. Iron and calcium tablets taken. No history of increased frequency of micturition or increased thirst or increased appetite. No history of burning micturition. No history of pedal edema, blurring of vision, headache. No history of pain abdomen or leaking PV or bleeding PV. No history of any hospitalization or any other complaints. Third trimester history. History of iron and calcium intake. Ultrasound done was told to be normal. Patient used to feel fetal movements adequately. No history of increased frequency of micturition, increased thirst, increased appetite. No history of any burning micturition. No history of pedal edema, blurring of vision, headache or high blood pressure. No history of abdominal pain, leaking PV or bleeding PV. Menstrual history. The age of attainment of menarche was 14 years. It was a regular cycle 26 to 30 days and 4 pads per day. It was not associated with dysmenorrhea and no history of any major passage of clots. Obstetric history. First pregnancy, it was 1.5 years back. It was a normal vaginal delivery, male, alive and well. Patient was 5 to 6 days beyond EDD when she developed pain which spontaneously, and then she delivered. Second pregnancy is the present one. Past medical history. No previous history of diabetes or hypertension. No history of any asthma, epilepsy or COX. No history of prior surgeries, no history of any blood transfusion earlier, no history of any drug allergies. Family history, no history of prolonged pregnancy in mother, no history of any diabetes in family, no history of any twinning in family, no history of any babies born with congenital anomaly or mental retardation in family. Personal history, appetite normal, sleep adequate, bowel and bladder regular, diet mixed, no history of any substance abuse, no history of any drug, known drug allergy, and no history of any use of any contraceptives. Dietary history, she is non-vegetarian by diet. Breakfast it was done by a 24-hour recall method. Breakfast 2 paratha sabji, 1 cup tea, 2 bananas. It was 540 calories, 7 gram proteins. Lunch she took in the previous 24 hours was 2 cup rice, 1 cup pulses, 1 cup chicken. Snacks was 1 cup tea, 2 biscuits. That is 120 calorie, 5 gram proteins. Dinner 3 chapati with ghee and egg curry. It was 500 calorie, 15 gram protein. So total was in the last 24 hours, it was 1950 calories and 47 gram protein. Required calories is near about 20 to 40 for this patient, and deficient calorie in the last 24 hours was 290. Summary. My patient, a 27 years old lady, gravida 2, para 1, living 1 at 41 week plus 1 day gestation with complaints of prolonged gestation. She can perceive fetal movements and has no other complaints. Examination. Patient is conscious, cooperative, and well oriented to time, place, and person. Patient is moderately built and nourished. General physical examination. No pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy, no edema. Weight is 64 kg. Height is 157 centimeter. BMI is 25.96 kg per meter square. General physical examination. Patient is afebrile. BP is 120 by 70. Pulse rate is 78 per minute. Respiratory rate is 16 per minute. Abdominal examination. On inspection, the shape of abdomen is globular. It is longitudinally distended. Umbilicus is central and inverted. Flanks are filled. Linea nigra present. Stria gravidarum present. No scars, sinuses, or dilated veins can be seen. Hernial orifices are intact. On palpation, the abdominal girth is 80 centimeters at the level of umbilicus, and the fundal height is 36 centimeters. Obstetric grips, fundal grip, soft, broad mass, felt, suggestive of fetal breach. Lateral grip, on right side, it was uniform, continuous, curved resistance, suggestive of fetal spine. Left side, it was irregular knob-like structure, suggestive of limb buds. The first pelvic grip, Paulick's grip, hard, non-ballotable globular mass, felt, suggestive of fetal head. Second pelvic grip, fingers are diverging. Auscultation, fetal heart sounds appreciated on the right spino-umbilical line, 130 beats per minute and regular. Systemic examination, CNS, no focal neurological deficit, CVS S1, S2 heard, no murmurs heard. Respiratory system, normal vesicular breath sounds heard. Per abdomen, no hepatosplenomegaly or any other abnormalities. Summary. My patient, a 27 years old lady, gravida 2, para 1, living 1 at 41 weeks plus 3 fetal movements and has no other complaints. Her vitals are normal, and in obstetric examination, a live fetus is palpated with fundal height corresponding to term and expected fetal weight of 3 kg with cephalic presentation and engaged head. The diagnosis is a 27-year-old gravida 2, para 1, live 1 at 41 weeks plus 1 day with post-dated pregnancy. Thank you.
Thank you.
Very good presentation. I think your video is not working very nicely. That is why you are not able to come with your video. I think Dr. Abuba from Assam is there and Seema is there. Hello? Can Dr. Apurva just unmute yourself? Apurva, please unmute yourself.
Unmute, Apurva.
Apurva, unmute.
He is not
Is
unmute.
Seema there, Ashish?
Yeah. Unmute
Is Seema
yourself.
there?
Seema is
Seema
not
there?
there. I think. Seema is not there.
Okay. So Apurva is there. So please unmute yourself.
Achha, before
Dr.
Apurva
Ashok.
unmute, I just want to add one thing, madam, with your kind permission, that in the abdominal examination, go to that slide on palpation. I just saw. I thought.
We'll start from the beginning.
Yeah.
At
Okay.
that time we'll go there. Yeah.
Okay.
So we'll, as you started, we'll go with the first slide. Please
Yeah.
ask him to start the first slide.
Go to the first slide. Yes.
In the presentation itself, do you think all the colors of a slide is very important for a presentation of a student?
Pardon?
I think a plain
pardon?
slide would have made things much brighter and better.
Yeah.
Yes,
Thank you, ma'am.
the designing of the slide is a thing which is not required for a postgraduate for a presentation, because your presentation has to concentrate on your words and not
Okay, ma'am.
on the design of the slide. The designing of the slides are all done for other purposes. So please, first thing is, please have your slides simple and well presented. If you go outside this country, the slide will be something which is normal. That is the first one I would like to say. The second thing which you have presented in the first slide is, yes, you have put the name. Usually, if you are putting a name of a patient, you should have taken the permission of the patient to put a name. Otherwise, you will have to say Mrs. X, Mrs. Y, Mrs. A. Unless we have taken a written consent of a patient for any presentation, even if it is academic, the name has to come only with the consent. So in your presentation, you should have started saying that as Dr. Ankur Pandey has taken permission from Shilpa to do this as a clinical presentation. That is the first thing that I would like to have. The second one is your date of admission and date of examination is, admission is the 8/5, examination date is 12/5. What, Ashish?
Yes, the exam.
What did you do on the last 4 days of your admission? Why are you presenting the present? In that case, you should have said you were admitted for, why did you admit her 2 days prior to her due date, even though knowing well that she had a first post-dated pregnancy? What was the need? As Dr. Ashish was saying, is she coming from a far-off place? That is the first question. And then in the present scenario of pregnancy not going beyond 40 weeks, were you keeping this patient in the hospital mainly because you are doing, you know well last month itself that you have to do a presentation of a case. So 8/5 to 12/5, you are keeping quiet and presenting these findings of 12/5 is one thing which is
I think admin, you please unmute Dr. Apurva Kumar Bhattacharya. Make him co-host. Otherwise, he cannot unmute himself. Admin, please. Dr. Apurva Kumar Bhattacharya is a faculty. Please make him a...
Sir, I have done.
Okay.
Thank you, Asita. Yeah.
Okay.
I think you can hear me now. Yeah.
Yes, we can hear you now. I think there is some network issues with Madam. So I think
Yes.
there's some poor connectivity maybe.
Thank you, Ankur. Thank you, Ankur, for your presentation.
Yeah. Good afternoon.
Yeah. Can I continue? Madam is Madam.
Madam को just बोल दो.
Thank you, Dr. Ankur, for your presentation. Yeah. I think you have presented a very good case. Patient is rather 27 years old and she's past her EDD, 41 weeks 1 day, according to your diagnosis. Only thing is that how can you establish that it is post-dated first? Ankur, can you hear me?
Yes. Whenever
I think let him go to the entire presentation.
Yeah.
Go for the crossing. Okay.
From past, yeah.
Go on. Go on to your next slide, please.
Next slide.
Okay, sir.
I think my connection was disrupted.
Yeah,
or...
your connection.
yeah.
We lost you for
Right.
some time. We are missing you.
Yes. Yeah. Can you say what is a middle class family?
Yes.
Yes, ma'am.
Yes.
Middle class, ma'am. It is according to the modified Kupusamy scale, ma'am. Classification where
You should have put that word Kupusamy scale. You
Okay,
should
ma'am.
have put that word Kupusamy scale in
Okay,
your
ma'am.
middle class family, isn't it?
Oh,
So,
okay, ma'am.
see, whenever we are making a presentation in our this thing setup, we should make it very clear what is the scale which we are using. And because socioeconomic is one thing that we have to make it very clear. Isn't
Okay.
it? Go to the next slide. Yes, go to the next slide. Yes. What is your next slide? What is your next slide?
Ma'am, it's the
She is a
ma'am, now
booked
it's
case, am
past
I right?
medical history which is going on, ma'am.
No, she is a booked
Should I
case,
move
isn't
ahead,
it?
ma'am?
Yes, third
Pardon,
slide.
ma'am?
Your
Pardon?
third slide. Your
Ma'am,
third
she is a
slide.
booked case, ma'am.
Third slide. Go back, go up, go up, go up.
Yes, ma'am. Third slide
Yeah,
is this
yeah.
one, ma'am.
Came for a regular checkup as a due date.
This was the first case
Delivery
slide, ma'am.
passed already. So that means she is a
Yes, ma'am.
booked case. So in that
Yes, ma'am.
booked case, what are the things you expect to have done in this patient?
Ma'am, okay, ma'am. Ma'am, for a book case, ma'am, we have to ask the patient, ma'am, the patient has to come for regular checkup. We have to see, go whether regarding the dating, ma'am. We have to confirm and establish whether that it was not a case of any wrong dates or such. The patient was sure of her last menstrual period, whether we had any first trimester ultrasound scan, and whether it was corresponding with her LMP or not. And after that, ma'am, on regular checkups, we have to do the regular NSTs, regular monitoring of the fetal status, mother status, ma'am, all the ANC investigations, ma'am, whether it has been done and what are the results, and whether the pregnancy by and large had been any complicated pregnancy or uncomplicated pregnancy, ma'am. So these all things,
Right.
ma'am, we could have done during prior to that, ma'am. Okay, ma'am.
In the present scenario of Government of India, do you ask
Yes,
for
ma'am.
a RCH registration?
Yes, ma'am.
RCH
Yes, ma'am.
number.
Ma'am, we ask for that, ma'am.
Yeah, that you should have the first thing. As a booked
ma'am.
case, regular case, we should get the RCH number. Otherwise, you can't record the birth certificate, online birth certification, isn't it?
Okay, ma'am.
Yeah. So whenever you say she's a booked case, the booked case RCH number should be the first one. Mrs. X, age at 29, add the registration of RCH number. That is the present one which has to be added up in Indian scenario. Am I right?
Oh, yes, ma'am.
Dr. Seema, please unmute yourself.
Yes, ma'am. Yes, ma'am. Yeah.
Do you think that this is very important? Because if they don't have an RCH number, it becomes very difficult for us to register the case with the birth certificate, isn't it?
Yes, true.
Yes. Go to the next slide. Your history of first trimester has been given.
Yes, ma'am.
Very beautifully. I think in this slide, I don't have anything because you have noted down all the points. Dr. Apurva, do you have anything to make a question?
No, ma'am. It's okay. Right now,
First time
till now it is okay. Till now it is okay.
Okay. Seema?
Yes, ma'am. History-wise, so far, okay.
Yeah.
I have one comment to make, Dr. Jayam Kannan.
Ah.
Dr. Jayam Kannan, I have one comment to make here. Go to the first trimester slide.
Yes.
And then second and third trimester.
Yeah, first trimester.
He has written, all 3 trimesters, I mean. He has
Second trimester of 5 months, quickening 5 months he has written. 5 months.
Okay.
I think time is better.
No, I'm not talking about your only second trimester slide. I'm talking about in general. You have taken 29 histories of no history of.
Yes.
That I have noted, counted. And the examiner is counting. Remember, he has to catch a flight also. So 29 histories of no history of written over there. That's the comment that I made. I just wanted to ask Dr. Jam Kannan, is it necessary to split the history into first trimester, second trimester, and third trimester? Why can't
I
you
do not think it is required, but I find that is why I asked you even before that, why so much details are being written and why so much details on diet also is
Pregnancy
written.
comes as a total event of 3 trimesters, and
Yes.
he has split into each trimester. First trimester, she has recorded a weight gain of 1 kg, second trimester 3 kg, and the examiner, while he was trying to put the third trimester weight gain in the calculator, he saw that there is no weight gain written in the third trimester.
But this weight gain in the first trimester, second trimester, third trimester becomes very, very important.
Yes, but add and give it total weight gain, that's all. Isn't it?
No, this has gotten very important this thing ashes when if come to the case of eclampsias, pre-eclampsias,
Madam, the
hypertension.
entire importance of weight gain during pregnancy is put under question these days.
Yes.
You need to have a total weight gain during pregnancy. That is
total weight gain is more important.
More important.
A split weight gain is not important unless you are dealing with multiple pregnancies. Yes. Yes. So
Ma'am, I have one thing to say, ma'am. He has not mentioned about screening for gestational diabetes, whether it has been done or not done, and whether it was done proper way.
Yes.
Ma'am, here I mentioned that, ma'am, underwent all ANC investigations, which was normal, ma'am. So I can think that
specifically you have to say about the GDM, because in your part of the country, Uttar Pradesh area, it is coming to be 40%, 50%.
PG class.
And in South India, it is now 30%. So that becomes very important. Diabetic screening was done is very, very important. Why it is important? We will come to you when you go to the last slide. Okay. So first trimester, second trimester over. The third trimester.
Madam, just 1 minute. In the second trimester, I think the date of quickening is important because we can calculate that. Yeah, date should be not 5th month. It should be approximate date at least.
Yes.
And
he has put it quickening at the
5th month.
Okay.
Yeah.
Okay, sir. Okay.
Yes. Third trimester. Seema and Apurva accept the history he has put in the third trimester. Please go to the third trimester.
Next.
Third trimester.
Next. This is second trimester. Yes, third trimester. I
think the third trimester you have put about iron calcium intake, ultrasound examination, frequency of burning micturition not present, blood pressure examination and other signs of warning signs and other things. Do you think that we should mention about corticosteroid intake as per the Government of India guidelines at that time, third trimester?
Ma'am, we can give a mention.
No, it is a must because 24 to 34 weeks, GOI makes very clearly corticosteroid should have been given. If you are in a primary health center and you are referring a patient to government or second as a CHC center or higher center, the form contains antenatal corticosteroid given or not. If you go through the Lakshya format, you will find antenatal corticosteroid given or not. If that is not mentioned, the primary health center doctor will be taken to task. As for the GOI guidelines, steroid intake in third trimester, 24 to 34 weeks, has been mentioned very clearly. So, see, everybody is not going to be in the private practice. Somebody may be in the government side. In that case, this is very important that steroid intake has to be mentioned. And in a booked case, steroid administration, as it has been discussed in the previous this thing by Dr. Ashish very clearly, is very important. 24 milligram of delta, this thing, and in 24 hours is a mess. Betamethasone is not the molecule which is available in our country. Am I acceptable, Seema and Apurva?
Yes.
Yes, ma'am.
Yes, yes. Anything else in the third trimester you would like to ask him?
I think the patient is intelligent enough because he wrote, as the Asisda said, that no history of pedal edema, no history of. So I think patient is much more intelligent. Yeah.
Yes, yes.
These are
Very
usually
good.
not mentioned in the history, not in the history.
Yes.
Yeah,
Yeah.
very much intelligent enough.
Okay. Now he has mentioned about the menstrual history, and the LMP is very clearly written. Since the menstrual history is very clear, there is
Yes,
no question about the expected date of delivery.
Yes, ma'am.
Yes. So now it comes to the question of what is meant by early post-term and post-term pregnancy, post-mature pregnancy. Can I request Ankur to give a small answer for the knowledge of the other doctors?
Ma'am, post-term pregnancy is any pregnancy which goes beyond 42 weeks of gestation, ma'am.
Yes.
That is called post-term. Dated is a word which is used for any pregnancy going beyond 40 weeks of gestation, ma'am.
Okay.
And then, ma'am, term is any pregnancy between 39 to 40 plus 6 days, ma'am. That is term. And then
which definition it is? 39 to 41 weeks. Any guideline you can mention?
Ma'am, I think it's WHO, I think, ma'am. I'm not sure of the name, ma'am, but I read it through the books, ma'am. So,
when you are given a topic on post due date pregnancy, you should have looked at what is term pregnancy. Term, if she is 38 weeks, would you not say her that she is a term pregnancy?
Ma'am, that is early term, ma'am. That is 37 to 38 plus 6 days is early term.
37 to 42 weeks. 37 to 42 weeks is term pregnancy as per ACOG and WHO also. It was mentioned as early as 2004. It has been mentioned as 37 to 42 weeks.
Yes, ma'am.
But yes.
37 to 42 is term, ma'am. 37 to 38 weeks plus 6 days is early term, and 41 till 42, ma'am.
Yes.
That is late term, ma'am.
Yes, that is what we said. Why are we worried about this due date and term words? What is it that you expect in this patient? Leave out that she has been having a previous normal delivery, but this time, what are you worried about it?
Ma'am, actually, ma'am, when any pregnancy crosses the due date, there are some physiological changes which starts happening, and which can lead to a bad outcome, like physiological changes like placental changes, then fetal changes. And placental changes like senescence of the placenta, ma'am, it starts happening. And if at all, if the placenta remains functionally normal, then there are problems of macrosomia going into the baby. And if the placenta has some functional deterioration, then there are acidosis leading to post-maturity syndrome in the baby, ma'am. So both ways, it is a complication, ma'am. Both ways, it is a complication. So that's why it becomes a line of caution as if the patient crosses 40 weeks of gestation, ma'am.
Okay, okay. Thank you, thank you. Go to the next slide. Go to your next slide. Obstetric history. What is it that you, this thing, your previous delivery has been 5 days to 6 days beyond the due date.
Yes, ma'am.
Am I right?
Yes,
then in this patient, this time, why did you admit her 2 days before the due date?
Ma'am, not ma'am, due date. Actually, ma'am, when the patient presented, when the due dates were passed, ma'am, so we admitted at that time. The date of
was she willing to get admitted, or you admitted her
yes,
on compulsion?
No, ma'am, right from starting, ma'am, we told her that your due date is this one, and so you should not cross that due date. If on that day, at least present to us. So she was a compliant patient, and she presented to us on that due date, ma'am, when it was just at the third crossing, ma'am. So we admitted when it was just crossed, ma'am.
Right. In this history, you have written previous post-dated delivery. What was the weight of the baby and the abgar of the baby in the previous season? Did you get any history?
Ma'am, I inquired from the patient, ma'am. she was not sure, but she told it was approximately 2.5 to 3 kgs, ma'am. But she was not sure.
2.5 to 3 kg.
Yes, ma'am.
So
But she
that
was not
means
sure.
it is in the lower range of your normal delivery beyond due date in this case. Was it in the same hospital or outside this hospital?
No, ma'am. She delivered in some other hospital, ma'am. In the last delivery was
If
some
she had
other
delivered
hospital.
in your hospital, you could have taken the previous case sheet, isn't it?
Yes,
That is
yes.
one advantage of delivering in the same hospital for this.
Yes,
In the
ma'am.
previous
Yes, sir.
pregnancy, in the
Uncle,
baby,
you'll
did
have
she
to-
have any jaundice in the baby?
Pardon, jaundice, regarding the jaundice in the previous pregnancy, ma'am, in the baby.
In the neonatal jaundice.
Ma'am, I asked, ma'am, she told the baby was there for 1 to 2 days and discharged along with her, ma'am. So probably I asked her any jaundice, and she told
So
no,
there was
baby was all fine.
notifiably no problem in the post-dated pregnancy, which we normally expect in this patient. Okay,
Uncle,
go ahead with your next slide.
Uncle, 1 minute, madam.
Yes, yes,
Actually,
go ahead.
past obstetric history should be presented in tabular form, as Ashish mentioned in the previous case. It should be in tabular form. Everything will come out there, whether immunized or not, whether what is the weight of the baby, everything will come out. So always put up all the PG students. You'll have to put up in the tabular form, make rows and columns in a box.
I think PG students are referring to the textbooks less often these days.
Yes,
It is
sir.
exemplified by the fact that they have forgotten that the obstetric history past was always written in a tabular format.
Tabular form.
Beautifully,
Yes,
all information, no information was missing, and there was no chance of missing any information also. Like the madam asked very pertinent questions, like what happened to the baby after delivery,
Yes,
like
yes.
the appearance of jaundice and other things.
Everything will come out.
These will be included, isn't it? So I request all the students to kindly put the past obstetric history in a tabular format always, with all the points mentioned.
And Ashish has also sent many times the circular on how to do this presentation.
Yes, yes, yes.
Isn't it? So those things have been a little forgotten. So
If you
every now and
permit,
then-
madam, I will do in this case also, if you get time, because the presentation of the student is very, very, very important.
Yes.
Every time I do that, but I find nobody is following that. That is one issue.
Yes, the post-dated baby, they have to mention all these things.
Yeah.
The weight of the baby, the appearance of the baby, the occurrence of jaundice, other complications, everything is very important for the next pregnancy, isn't it? Okay. Can we go to the next slide?
No history. Okay, next.
Yeah, past medical history.
No history.
Anything particular you want to ask, Apurva or Seema?
Yes.
No, he has put about the diabetes,
No,
asthma, surgery, and other
No
things.
history.
It was also mentioned in the previous case. I think past medical history is not related to the due date going beyond. Next slide, please.
He has written already.
Family history.
No family history.
Yeah.
Okay.
Is family history becoming important for a post-dated pregnancy? As well,
Yes, ma'am.
we on to the etiology of postdatism.
Yes, ma'am. It is very important, ma'am. Usually, ma'am, in that the patient herself was a post-dated delivery, ma'am. If she is in a post-datism, ma'am. So many times a strong correlation has been seen, ma'am. And any history of diabetes, in the family, ma'am. Any history of any babies born with any congenital anomaly, ma'am, especially anencephaly and all, ma'am. So there are high chances of postdatism in them, ma'am. So it's very important.
What are the possible causes of post-dated delivery normally? Etiology of post-dated delivery?
Ma'am, etiology of, if we divide it, ma'am, the maternal factors and the fetal factors, ma'am. So maternal factors, ma'am, the primiparas, ma'am, there are high chances, and there are high chances in elderly multigravidas also, ma'am. So both ways, ma'am, there are high chances of postdatism. There are genetic predispositions also for postdatism, ma'am. And if we see the fetal factors, ma'am, then some congenital anomalies, ma'am, like anencephaly and adrenal hypoplasia, ma'am. Adrenal hypoplasia, ma'am. They can lead to, ma'am, postdatism, ma'am. Then,
but nowadays we are not seeing anencephaly at all. So probably that has to be deleted from the textbook of obstetrics, which I feel. Am I right, Seema?
Yes, ma'am. That's true. They're diagnosed very early and terminated.
Yeah, so Yes, I know you are going to say about anencephaly, but this is not the era of allowing anything. Some of the things have to be outdated in our textbooks. That one outdation has to be an anencephaly. Yes, Apurva, anything you want to say?
Actually, if the patient do not come for antenatal checkup, we may miss sometimes anencephaly. That is another point. In
Yes.
Northeast,
Sometimes we may miss, but nowadays,
like the previous case.
99.99%, I think we are.
Otherwise,
It should be put on the one of the outdated diagnosis.
For positive pregnancy, age is the factor, madam. Age and elderly primary with a family history is always there. So that should be always taken into account whenever you take the history.
There is a comment in the chat box. In Orissa, rural areas, ultrasound is not done. But I think in the NRHM, this thing, a village nurse is given a particular need to know, go through the village visits, find out any woman who is pregnant, and that nurse has to take the patient to the hospital and see that she is taken care of. In Tamil Nadu, Kerala, and this thing is very important. Otherwise, if the patient goes in for any complication during delivery, the nurse is being suspended. So, in our part of the country, no patient can miss a village health nurse, and registration, everything is a must. We have in Tiruchirappalli a Trichy antenatal tracking system, in which all doctors, private doctors, put their complicated cases and give the RCH number so that the government machinery is able to follow them after discharge home. So there is a comment I saw in the Orissa. Probably the system has to improve with the village health nurses. So can you move to the next slide?
Dr. Ankur, I just want to ask one thing. What is the predisposing factor in this case for the patient to go post-date? What is the predisposing factor in your patient?
Ma'am, frankly speaking, I could not find out any major predisposing factor. Just one thing which I could clinch upon, ma'am, it was that she had a history of post-dated delivery, ma'am, in the last pregnancy, ma'am. Apart from that, ma'am, I could not find any thing which could correlate it, ma'am.
Yes. Yeah, that is very important. That is a very important clue because the risk increases by 30% if she had the previous delivery. Yeah, so that is the main factor in your case.
Correct, absolutely, because the patient, when she has delivered a baby beyond the expected delivery in the last pregnancy, is always complacent and puts that complacence into family's head, and that is transmitted to the hospital also. So it's a very important factor that once a patient experiences postdatism, it tends to recur, apart from the obstetric chances.
Okay, that's correct, Ashish. So that is why I asked, why did you admit the patient on 8-5? When you know well that 1 in 3 patients, because we are already short of beds in medical colleges and in district hospitals. In private, if it is there, patient has to pay for it, economical concerns. That is why I asked, why are you admitting the patient? Okay, can you move to the next slide?
Yes.
Dietary history.
Next.
Ma'am, should I move to dietary history?
Personally. Yes, personal history you have said.
This is
Can
actually,
you move to the dietary history?
This is actually functional history, and the diet history should come separately.
Yes,
yes, put a dietary history.
Yes,
this is the dietary history, ma'am.
Yes, dietary history. Yes, dietary history. You have said about non-vegetarian diet.
Yes,
what is meant by a mixed diet and a non-vegetarian diet? You have initially mentioned a mixed diet.
Yes, ma'am. Ma'am, same thing, ma'am. A mixed diet only is that, ma'am. They both have same terms, ma'am. So can be used, ma'am.
So what is meant by a vegetarian? A vegetarian and non-vegetarian, the definition is very, very difficult. But as per your this thing, you have put 1 cup chicken. Is it every day she takes a 1 cup chicken?
Ma'am, actually, ma'am, this analysis I did with by 24-hour recall method, ma'am. So she told that she takes non-veg, not every day, but in a week, twice or thrice. But in my 24-hour recall method, ma'am, yesterday she took this, ma'am. So I mentioned it,
So
ma'am.
that means she is an occasionally non-vegetarian patient.
Ma'am,
Every day.
yes, ma'am. In a week, ma'am, twice or thrice, ma'am, she takes, ma'am. That's it, ma'am.
Yeah, you should go into that Kupusami scale of all these details. You will
Yes,
find what is the dietary pattern. Kupusami scale is something which, because I have been into social obstetrics right from my thesis day, because my thesis was comparative estimation of hemoglobin in urban and rural mothers. So I know about this Kupusami scale. So she is an occasional non-vegetarian. And you have put a diet, she has taken 47 grams of protein. How did
Ma'am,
you calculate?
ma'am, I did the just calculation, ma'am, rough calculation by the constituents, ma'am. So by that, ma'am, I calculated it, ma'am. Just a
Yeah.
Dr.
But these are
Ankur,
not too many.
I have a very polite question to you, to be politely asked. Dr. Jayam Kannan also is there. Do you think that this much of details of the diet is necessary in obstetric cases?
Yes.
It is very important to find out time for everything and write down a good summary at the end of it. If you go on calculating how much a paratha cost and how much the banana gives you, and the lunch contains how many cups of rice and how many cups of chicken, then just approximately tell me how much time do you need to take this history. And this all this time is deducted from your allotted time of 40 minutes. Remember that.
Yes.
Yes, sir.
Correct. Yes. So this detailed dietary history is less important in your presentation. That is what we feel in both your presentation. The dietary history is not too much required, and this calculation is not that much easy also. So please erase this idea from your mind that you require this. Now you go to the next slide. So you have given a very 3-line summary. As Ashish has said in the previous case, an elaborate summary should have been presented. What could have been your better summary?
Ma'am, this is the summary of the history, ma'am. So final summary I have given in the last slide, ma'am. So this was the conclusion just by history, ma'am, which I could.
Is it essential? Is it required that you put a summary of the history and then summary of the examination, then summary of the case, then summary of the diagnosis? You don't need this, right? You need only one summary.
Need it.
At the last.
This is not required.
Summary at the
This
last.
slide is one thing which is not required, because we don't summarize the clinical, the history. We summarize totally a patient. It is not a piecemeal summarization we do.
Correct. Yeah. Go
Isn't
ahead.
it?
Complete it.
Go ahead. Next slide. Examination. Next slide.
Yes, ma'am.
Do you require the word conscious, cooperative, well-oriented?
Ma'am, it just, ma'am, actually it gives status, mental
Do
status
you
of the
expect
patient.
an obstetric patient who is walking into the hospital
yes, ma'am.
to be anything different from this? Is this a must in an obstetric history?
Ma'am, I feel we should give a mention at least that the patient is conscious and oriented, ma'am. Fewer times, ma'am, we can find the cases, ma'am, where a patient may come drowsy. That may give a clue that we have to actively manage the case, ma'am. So I think at least a small mention should be given, ma'am.
Yes, small mention can be a clinically stable patient.
Okay, ma'am.
That word. About Ashish? This is like a neurological examination.
Before commenting on that, Ankur, just go into the abdominal examination slide.
Just
found out something. Abdominal examination.
Yes.
Before this slide, the previous slide.
No, after 2 slides, abdominal examination comes.
Yes.
Okay, I
think slide after next.
Next slide. Next.
80 centimeter.
Abdominal girth is 80 centimeters. Girth is always measured in terms of inches, as per the textbook suggestions at the level of the umbilicus. Just remember that. The symphysis fundal height is in centimeter. The abdominal girth is measured at the level of the umbilicus in inches.
Yes. Not in centimeters, in inches. What is
Yeah.
meant by fundal height term size? Do you
Ma'am.
expect this fundal height term size in a post-dated pregnancy, or you have the falling forward and the height?
No, ma'am. It was term size, ma'am. Term size only, ma'am.
What is meant by a term size?
Term size.
Ma'am, term size, especially when we mention, ma'am, that there are fullness in the flanks, ma'am. So the fullness in the flanks when correlated with the height, ma'am, then we
So these
end up.
details you should have given better and more than what
ma'am.
you have given for the dietary examination. Am I right?
Okay, ma'am. Okay, ma'am.
Okay. In your dietary examination, it was not so much required, whereas your fundal height and other things should have been mentioned little more better than what you have said.
Okay, ma'am.
Am I right? Yes.
Okay, ma'am.
All your stria gravidarum, umbilicus central, aborted, flanks filled, linea nigra present, stria present, all these things are quite all right. But
Okay.
your abdominal examination, girth, the level of this thing, and the fundal height is also very important. You should have measured it with the tape also. That is what
Okay.
is required. Comments
Okay,
from
ma'am.
Apurva and Seema?
Yes, ma'am. It's correct. You'll have to see the gut and you'll have to measure it in inches, which corresponds
Okay,
to the gestational age after in the third trimester. And
Okay.
fundal height should be written, I think, symphysis fundal height.
Okay.
Yes, that should have been written.
Ma'am, I want to add one thing,
Yes.
that no mention of assessment of lichorrhea has been mentioned clinically during
yes.
palpation and everything.
Yes.
No mention is being done.
Clinically.
That is very, very
Clinically.
important in a post-dated pregnancy.
Clinically, you'll have to see.
Yeah, post-dated pregnancy, that becomes, especially in a booked case, you could have examined the patient last week, and from the last week to this week, what was the difference? These clinical details in a booked case becomes very, very important.
There
The
are
findings
things-
which has been noted earlier should have been mentioned. Am I right, Ashish?
Yes, 2 or 3 things are also missing here, like Dr. Seema said. And also you should mention about the fetal movements if felt, and the contractions, if any. All these things you must mention. But amount of lichorrhea clinical assessment is extremely important in postdated pregnancy. Remember that.
Yes, that is very important. Yeah, go to the obstetric grips. Next slide you have given. You said fundal grape, suggestive
Yes, ma'am.
of fetal breach.
Yes, ma'am.
Then right lateral grape, right side spine,
Yes,
left side butts.
But
First pelvic grape, no palpable globular mass, suggestive of fetal head. Second pelvic grape, fingers are diverging. I think you have to, Seema and Apurva has to comment on these findings.
Suggestive of fetal head.
Yes, fundal grape, fetal breach. Then right, so that means is he feeling with the right lateral position of the baby? That means is he expecting RAO or ROP?
Yes, that lotus.
Isn't it? Then the first pelvic grip, he has said fetal head. In the second pelvic hip grip, he has said fingers are diverging. So what is the clinical diagnosis which Ankur is expecting with a divergent second pelvic grip?
ma'am,
Can you
it
come
means
out
that
with your suggestions?
ma'am, it's a question to me, ma'am.
See, first pelvic grip, globular mass, fetal
Yes,
head.
ma'am. Yes, ma'am.
Second pelvic grip, the fingers are diverging.
Yes, ma'am.
Diverging fingers means what is the occipito-frontal presentation which you are expecting in this patient? Are you
Right.
expecting to think of a globular presentation? Just an ROT, because you have said back is on the right side. So I like to talk about right side only.
Yes, ma'am.
If it is an ROP, you will not have a diverging fingers. Am I right? Ashish?
Actually, I just wanted to make quite a few comments on this obstetric grips. The first few slides are okay. But in the pelvic grip, you should be very careful. Nowadays, we are
Yes.
depending less and less heavily on the so-called first pelvic grip, second pelvic grip. They're okay. They should be there written. But one indication should be given in all postdated pregnancies about the engagement of the head. And for the
Yes.
engagement of the head, you must mention the Crichton's maneuver. That is the fifth law, rule of five. 5 fingers estimation
5, 5, 5.
by the students, and that should be placed. They're like 5 by 5 or 3 by 5 or 2 by 5. This should be given
That is
because
very
today we are measuring the engagement of the head not by PV examination, not by diverging
Yes.
fingers, but by the presence of fifths above the symphysis pubis.
5, 5. So this baby is a right lateral positioned baby. That means the baby is not an engaged baby. Is that correct? Do you think it is correct? Your presentation, Ankur?
Ma'am, ma'am, these were the clinical findings which I got, ma'am. It might be that some spontaneous correction can happen afterwards, but
Okay, okay. Okay, you are
student.
student. We are all very old people. So we are just giving you only suggestions. That's what I said. It is not an examination. It's not a passing the examination. Don't be tense. Relax. Let us discuss. That is why I brought in all this. Because in the previous case, we have discussed about the 2 by 5, 3 by 5, and this thing. In this patient, at least we should have found a 2 by 5 to 3 by 5 to find out a engaged baby, isn't it? That
Yes,
would
ma'am.
have been a thing which you should have added. And if you are presenting a next case, you should add this 5 by 5 presentation instead of putting a polygrip and the second pelvic grip. And the
Okay.
diverging fingers finding is very, very dangerous because you are committing yourself on something saying
Yes,
that this baby is not going to engage. That is very, very important. A diverging finding is some years ago, decades ago, we were looking at it, but this is not the one in the present era that is to be said. So in the auscultation, you have said fetal heart sounds appreciated. Are we doing auscultation or were we doing Doppler or were we doing
Generally, ma'am, we check by stethoscope, ma'am. Then if at all some doubt is there during practicality, ma'am, then we go for Dopplers, ma'am. But
which
mainly
hospital you are there?
ma'am, in
You are
DDO,
there?
in a government hospital, ma'am, DDO hospital, ma'am.
It doesn't have a Doppler?
It has a Doppler, ma'am. It has a Doppler.
So in a postdated pregnancy, would you not be careful to use a Doppler than
Yes.
an stethoscope?
Yes, ma'am. We should get
Seema?
it.
Yes, ma'am. Definitely, ma'am. Over here, you need to reassure the patient also that fetal heart is good. If the relative is there, some staff, other witness, in case some mishap happens, at least in the OPD, you have heard the fetal heart and told at that time, yes, it's good.
So here I will really request Ankur not to think of auscultation with a stethoscope, I would like him to do a use and a Doppler as Seema also has correctly accepted. Apurva also should be accepting, Ashish also should be accepting that we should reassure the patient, reassure yourself and the relatives that in spite of the postdatism, the baby is all right. Because pregnancy never to go beyond 40 weeks is the dictum which is being dictated by Lakshya and other things. So in that case, you have to be very clear to use Doppler, record it, and show it to the relatives also.
Ma'am,
Okay.
in examination, ma'am, are we allowed to carry a Doppler along with us, ma'am? In the examinations, ma'am.
You can demand it from the ward where the
You
patient
can
is
demand it. You can demand it from the ward.
Okay. Okay, ma'am.
Yes.
Ankur, I
Yeah.
just wanted
In,
to make two comments here.
South side, Doppler is kept in the obstetric
in every
examination hall.
hospital these days. No, madam, I just
Yes.
wanted to make one comment that why this priority of examination of a postdated pregnancy is being shifted. You see, the most important findings that we are very worried about is that the fetal movement, there is no record of fetal movement in anywhere in
Yes,
our
at all in your record.
Okay, and nor is there any comment about the fetal movement from the patient, count from the patient. So I think these two are very important. And the second thing I would like to comment, Dr. Seema said, that the amount of glyceramniae, clinical assessment must be there, because otherwise, how can you compare your finding with the later on the investigative findings like ultrasound finding, etc., and take decisions? Very difficult, isn't it? So these two things must be there in the abdominal examination of a post-dated pregnancy.
Okay, that's correct. So we are correcting you with these things. And when you go to the exam hall, know very well that there will be a Doppler machine available, and also you can request for it if it is not kept there. Probably somebody may purposely keep it outside.
You carry a tape. The tape will not be provided by the hospital.
Yes. Yeah, tape,
You
pencil and other things is yours. A Doppler is by the examiner hall. The assistant has to keep a Doppler. Go to the next slide. Yes. Systemic examination. We do a systemic examination before abdominal examination or after the abdominal examination?
Ma'am, generally, ma'am, it's both ways, ma'am. Generally, some mention it prior, ma'am, and some after main systemic examination. Like obstetric, ma'am, main obstetric we have done, then summarize the rest systemic, ma'am. And the part, ma'am, which has to be examined in detail should be mentioned first, ma'am. It is books, ma'am.
Ashish, Sima,
No, but
which is first,
I agree
next?
with Dr. Jayam Kannan. You have the general survey, general examination first, followed by the systemic examination, and then because abdominal examination is local examination. You finish the general survey and the systemic examination first, and then you go into the local examination.
So
may I add here something?
Yes.
May I add here something, sir?
Yes.
It is a standard practice. It is a standard practice which all students have to follow. First, systemic examination, and here also you have written in the end for abdominal examination, no hepatosplenomegaly. So this is not the way. Abdominal examination include organ as well as obstetric examination.
Right.
So it is a standard. It is a standard for all. I don't know why you are deviating from the standard.
Yes, you can't go away. You have to do the inspection, then go by the head to foot, and then only come to your area of concern. Your area of concern is tummy, but the tummy comes after this thing, the systemic examination. So this slide should have been put earlier to your obstetric examination. Then, so all the faculty have accepted that the systemic examination you should write earlier. Ankur, note it for your future guidance. It is not to point out anything wrong, but it is for your future guidance and also for all the students who are looking at it now. Apur, anything?
No, ma'am. Oh, it's okay.
Okay. You said everything is okay. Now, now you are coming to the summary.
Yes, ma'am.
Am I right?
Yes, ma'am.
Yeah. Here your summary, elaborate summary or small summary? Now you find.
It's an installmental summary. Second installment system. I think before Ankur closes it, madam, if you kindly permit, I will just present a sample of a summary in this particular case, just to give an idea about how the...
Okay, please do it, Ashish. Please do it. We'll wait.
Yeah, because you see, my point is that you do not present this way in the examination, right? You have all the details, but in examination, in real life, what happens is that the examiner comes and takes away the sheet from you and then asks you the question, what is your case?
Yes.
And the student...
Please give the summary, Ashish.
Yeah.
What is your summary expected?
Okay. So I'll just present...
Now you are my student. Give me the summary.
Yes. See, this patient, Mrs. S, 27 years, gravida 2, para 1, living 1, carrying 40 weeks, 6 days, sure dates, wife of somebody, so not that necessary, a housewife belonging to a middle-class family and staying approximately 10 kilometers from our hospital, came to our OPD with complaints of prolonged pregnancy. She has crossed her expected date of delivery by 6 days and seems to be worried about that. In her last pregnancy too, her pregnancy continued beyond 40 weeks, after which she had a spontaneous vaginal delivery of a living male baby at 40 weeks, 5 days, weighing so and so kg, who cried at birth and had no signs of jaundice, infection, respiratory problems, or admission in SNCU or NICU. In this current pregnancy, she has been adequately antenatally cared. All the antenatal investigations are normal, and she received IFA prophylaxis and injection TD. She had no major antenatal complications or diseases, and she gained 4 kg of weight in the first 2 trimesters, but no record available in the 3rd trimester. She can perceive fetal movements and has no other complaints.
Very good.
Her past medical, surgical, and gynecological history has been unremarkable. She's on a non-vegetarian mixed diet, but has total 1950 calories with a 47-gram protein. And the required calories and deficient calories were 3,350 calories. On examination, she's alert, cooperative, oriented, and gave us a good history. She is afebrile, does not have any health issue. Her BMI is 25.96 kg per square meter. Her blood pressure, pulse rate, and respiration rates are all normal. She has a normal systemic examination. Per abdomen, she presents with a single fetus with cephalic presentation, height of the fundus and SFH corresponding with period of amenorrhea. 80 centimeters should be converted into inches of abdominal girth, adequate amount of liquor amniae, no uterine contractions, and a normal fetal heart sound. Estimated body weight is average, baby weight is average. So a provisional diagnosis is 27 years, G2P1L1 at term with prolonged pregnancy.
At post-term.
A prolonged
Or
pregnancy.
as per your this thing, yes, post-date. Yeah, that is
not prolonged pregnancy. The current terminology is prolonged pregnancy. And there was a question in the chat box also. And if your crossings are going to finish over here, Dr. Madam Jayam Kannan, then we will have a discussion on these terminologies like post-datism.
Yes, I also have. Here, actually, she has put the expected weight as 2 kg. Does it alert you as a post-dated pregnancy, 2 kg baby?
I think
post-dated 2 kg baby. Earlier baby was 2.5 to 3 kg. He did not remember very clearly. It was 2.5 kg. Now this baby is 2 kg. Does it alert you something? Do you think that you can just present this case like this, keeping the patient in the hospital for 5 days?
Its fetal weight is 3 kg, ma'am.
It should alert you the
3
possibility
kg.
of
It's 3 kg, ma'am.
also. Yeah.
It's 3 kg, ma'am.
Yeah, in your earlier slide which you have sent, it was 2 kg. That is okay. Now it is 3 kg. You have put
Maybe
it.
he was
It is
doing
okay.
trimester-wise baby weight, maybe.
Maybe, yeah. No, they have sent an earlier presentation, which I have gone through. In that, they have written as 2 kg.
Okay,
So
okay.
now you have made it 3 kg. That is okay.
That's okay. That's okay.
Yeah, okay. So now we are saying, as she said, we will go for the discussion of the terminologies which are coming into it. So start the discussion, Seema.
And I would like to invite Dr. Ashok Kumar also in this discussion.
Yes.
Because, it's a very important issue. This terminology should be very clear to the...
Yes.
Ankur,
What is this?
Yes, sir. Yes, sir.
2004 ACOG defined it as post-term pregnancy. And it talked about prolonged pregnancy, post-dated pregnancy, post-datism pregnancy. But in India, we still have 7% of the pregnancies going beyond date. Most of the babies are delivered, 80% are delivered before 39 weeks. 39 to 40 weeks is around 10 to 12%. 4% deliver at due date, 7% go beyond due date. Is this acceptable?
Yes, ma'am.
Yes. Ashish, Ashok, there was one recent paper from India which said 7% of the pregnancies in India are post-dated.
And beyond 41 weeks, it is 7 to 10%, but beyond 42 weeks, it is 1%.
1%. Okay. From your hospital data, it is 1%.
Beyond 42 weeks, it is 1%.
Yeah, actually speaking, many of these pregnancies are terminated earlier, and Dr. Ashok Kumar was saying that some of us feel that they should be terminated 39 weeks of pregnancy. So there lies the confusion, and there's little data available. about the babies delivered beyond 42 weeks of pregnancy. So it's very difficult to say. But yes, around 7% of babies will have delivery issues beyond the expected date of delivery. That is true. And that is of concern. Now, whether we should go for, particularly in a patient who has given the history of post-dated pregnancy or prolonged pregnancy, not post-term pregnancy, would you like to allow this pregnancy to continue beyond the expected date, or you take out the baby at 39 weeks? Now, suppose that it depends on the previous pregnancy history also. As we saw in this case, the baby suffered no complications and there was no admission in intensive or NICU, and the antenatal period was uneventful also. Here also in this pregnancy, now is it pertinent to wait for the expected date to come there and then wait for the expected vaginal delivery? That is the point of discussion. Yes, Dr. Ashok Kumar, what is your opinion?
Sir, actually, yes, actually, see, there are difference of opinion at the moment, but the data is coming that 39 weeks and beyond.
Yes.
One should be more alert and one should electively terminate, because the question is, one is, if you leave pregnancy for a long time, we should understand there is a uteroplacental insufficiency because of the aging of the placenta. This is a normal phenomenon. It is physiological. So there is a fear that something may happen to the fetus because of the compromised blood supply as aging occurs. Number two is, if you try to deliver these baby early in a natural process, physiologically, their cervix may not respond. There are more chances of induction leading to cesarean in unfavorable cervix. So now the evidences are coming that, number one, induction is safe. That is, they are saying, and we have so many methods, so many drugs available. They say now induction method is safe. So less of complication. Number two, there are evidences which are coming that after 39 weeks, if you do the induction in these patients, the cesarean rates are not increased. Yes, there are few trials, few studies, and SFM and one more society have agreed and recommended also that 39 beyond the pregnancy should be terminated in low risk patient. And I'm not ARRIVE trial. Yes, ARRIVE trial started this story.
ARRIVE trial is the one which has got a good work.
Yes, which started this story. So, but what is happening is that we have to balance the situation. We should see what is the cervix, where the patient can be induced, what are the condition overall, what are the setup at your hospital, in your center also. And like, if you see, RCOG has not still changed. They still say 41 weeks.
The old one is still maintained.
They say 41 weeks.
Yes,
41 plus. Still 41 weeks, you continue monitoring the baby, continue monitoring the mother, and then try to deliver them if they are not delivering by 41 weeks. So the another thing which came into picture is that if you feel the baby is mature, there is no point continuing the pregnancy. Number two, you are putting infrastructure, you are putting the burden of monitoring also, because patient will be followed up, patient will come to the center, you are using the manpower, you are using the hospital resources. So why not deliver the patient when it is good enough to deliver them? So this concept is coming up, but at the moment, we are not sure at what gestation we should deliver. In my hospital, I am following 39 to 40 weeks we should deliver. But I understand that most of the, or in some places also, on EDD also, they try to deliver the patient, and they say, no, we should not wait beyond EDD because there is a risk of fetus. So because of the uteroplacental aging. So they are different concept, different people have different practices. So that is why we are here. You all can give your views and your practices, what are being followed at your center, or what are you following at your place, so that our students, or we all have that things in our mind, that how to proceed and under what circumstances. Because I told these are the three concerns which are there. One is that placental aging. Second is, if you are monitoring for a long time, burden on the infrastructure. And number three is you are intervening in a unripe cervix, so probably more chances of cesarean. So these are the three concerns with us. And yes, sir.
Yes.
Yes.
Actually,
To take you to the expected date, Ashish,
yeah.
if you don't have a patient who has got a regular menstruation, she has got a menstruation between 20 days to 50 days, there are some more findings which has to take up for a due date costing. That is as per the present, this thing arrive trial which has been given, a positive HCG findings from that, the date taken up in the next 34 weeks. Then 20 weeks from the rate of a Doppler measuring the fetal heart. And this thing, if you are able to make a CRL finding very clearly, from that CRL finding, we have to calculate the 39 weeks. That is what has been given very clearly in that. And ultrasound before 20 weeks, if it has been done, it should be mentioned in that ultrasound itself, whether it is consistent with the date or not consistent with the date. These are the newer things which we have to take up from the past, this thing which we are looking up with the auscultation with the stethoscope to the newer findings, because labor induction after 42 weeks, it becomes in 82% or 80% of cases, it becomes unfavorable as per the detailed arrive trial also.
See, madam,
Yes,
we
sir.
have to, what Dr. Ashok Kumar has said, very significant.
Yes.
The Atlantic Ocean has become very famous. Why?
Yes.
Either side of it, always there is a quarrel. You talk about
Yes.
reproductive endocrinology, ASHRAE and ASRM. You talk about the delivery, you talk about induction of labor. Everywhere there is some controversy. That will be
Please
there.
stop sharing the screen.
Yeah.
So that we can.
Yes, that is better. So that we go for a,
Yeah.
they say. Yes,
And
that is.
in this admixture of controversy, the students are there somewhere, we are somewhere there, we are providing the service. Now, you cannot talk two things together in the same breath. You are saying the commonest cause of unfair number of cesarean section is termination of pregnancy and by induction of labor in an uncomplicated pregnancy. On the same time, you cannot say that you cannot allow the pregnancy to continue till expected date of delivery. I'm talking about uncomplicated pregnancies, and then decrease the chance of cesarean section. So I think we are actually in a doldrum these days, and decision is really individualized in each case. I agree with that. But having said that, there should be certain principles. See, my counter argument to what Dr. Ashok Kumar has said, placental aging is not a new phenomenon. It is happening over the years, centuries, isn't it? So it is unlikely to affect Mother Nature is never so cruel. So I don't believe in that. But then there are a lot of believers in the theory. They have shown by statistics that yes, placental aging does happen even in normotensive patients. Normotensive patients do have HELLP syndrome, do have eclampsia, etc., and growth restriction. So all these things you have to, I think, individualize the case. And at the point of any suspicion, even a small smell of a growth restriction or a hypertensive disorder or any organ damage, I think you should go for the earlier termination. But otherwise, I think up to the expected of delivery waiting is worthwhile in our country. If we really focused on the reduction in the huge number of cesarean sections, that is what my take is. But I'm talking about uncomplicated pregnancies.
Dr. Seema, please.
Yes, sir, having taken your point, I want to say that many textbooks, they are recommending induction at 41 weeks. They are saying that 41 weeks is ideal. So you've given the benefit of spontaneous labor also to the patient also. And the risk is not that much at 41 weeks. So the final take.
Yes. What we follow, we wait till 7 days. After that, we start induction, so that within 10 days of the EDD they deliver. And nowadays,
Dr. Sheila and Dr. Urushi, if you are here, if you are there, you can put your comments also. What is your opinion? Because we are discussing now, because in the end we have to give something to the student.
Yeah. I think RCOG has won this over ACOG in this battle. For the time.
Yes. For the time being, yes.
For the time.
Yes, sir.
ACOG 2020 says continuous cardiothoracic monitoring should be offered to all women in labor after 42 weeks.
And somewhere in the middle,
Indian scenario.
Yeah, somewhere in the middle, WHO is standing there with a whistle in their mouth, and he is blowing at regular intervals, that see, you are going beyond the level of estimated level of C-section. With different governments are responding to this differently. And I have heard that some punitive measure taken by the state government also, that is unfair. The doctors are really in a dilemma. But I think that
Lakshya also says the same thing, continuous cardiotocographic monitoring in all pregnancies, in the second stage of labor, and also in post-dated pregnancies.
Our Manyata is not saying that.
So Manyata doesn't ask you to deliver after 40 weeks at all. Yeah. Manyata is meant for nurses. It is not meant for.
Sir, we have to close it now. We are passing the time also. So I will try to summarize it, and you may add on. What I will say for the student, that whatever, see, we have tried to give you different different concept and different steps or different management options in these situations. Now you have to go and read in detail, because you should know the pros and cons of each direction, like 39 weeks, EDD, and 41 weeks. You should know pros and cons of each and everything in detail, so that you are able to justify at the time of exam that what is the, see, there is no correct option at the moment. It is, as Dr. Ashish sir has told, it is individualized. You have to individualize the patient. You have to see the patient. What is the situation at that point of time? What is the profile of the patient? And what is your center? So you individualize your management and think and plan. You have to choose one option for the patient, but you have to justify. So you should be able to have the pros and cons. You should learn all these things and then try to discuss in the exam with your examiner that how will you approach the patient and what steps you will do for when the patient is near her EDD. So, sir, you want to add something here?
Yes, just recently 3 terms have been added to the obstetric dictionary. The one is early term, mid term, or other term, and the late term. So all these terminologies, they are nothing but just the duration of pregnancy split in different 39 to 40, 40 to 41, and 41 to 42, something like that. So I think these are a close differentiation between the different conditions, but the decision has to be taken by the obstetrician treating the patient. And I think that what I find today, the diagnosis of uteroplacental insufficiency, be it because of normal placental aging, be it because of hypertension, diabetes mellitus, or be it any other condition which we cannot diagnose or identify in many cases, I think you have to have a close watch on the fetus and the mother, and then only you can take this decision. So it has to be a decision making with a clinical context in mind, not only lab, not only patients or not only doctor's point of view, but also the it's a patient everyday monitoring is important. And we need to find out some way so that we can transmit this knowledge to the patient, because it is not possible to keep the patient admitted for 3 weeks or 4 weeks time. And therefore need to transmit some of the information to the patient that watch this, watch that, and alert me whenever something of this kind of happens. So we are yet to develop that. So I think every case has to be individual, and that leads to the jugglery, and that leads to a lot of indecisions and difficulty in decision making these days. So students,
at least we expect from the student that they should know all the points, pros and cons of each situation, and they should be able to justify. We are not going to mark them on what choice they have given. We want to know how they are going to justify each situation. So that is more important than giving. There is no correct answer in this. So that is what we want to emphasize in this case, that students should be able to discuss the case. They should be able to give all the points in favor and against the situation, and then we will be able to justify the marks to the student also.
I've heard students answering this question. Every possible way we have asked this question, they answer only this one way. Sir, according to RCOG guidelines, the 41 weeks should be
yes.
According to ACOG guidelines, I think you can say this. There is no harm in saying this, that you are well read, but add one sentence before and one sentence after this. What is the one sentence before you say this? You say that there is no uniform consensus on this.
Yes.
And add one sentence after this, that each and every case should be individualized depending on the clinical condition. I think if you add 3 sentences like this, your answer will be complete.
That is what we are again emphasizing again and again, that they should not know only the RCOG guidelines, they should know the other statements also. This is what the
I
point
think
is.
we should have more of the Indian guidelines which are
Yeah.
coming up. As per Lakshya guidelines, I think we have to go. Otherwise, medico-legally, you will not be able to pin down your court
Yes.
because they only go by the GOI guidelines, Government of India guidelines, which states induction of labor at 39 weeks in favorable cases. In unfavorable cases, depending on the situation, proceed accordingly.
So we are
Thank
in
you,
time,
madam.
sir.
Thank you.
We are in
Yes,
time
we are
and
going post timing.
we should close this session over here with profuse thanks to our faculty
Thank
members.
you, Ashish.
with
Thank
the
you, Ashok.
students, and
Thank
Dr.
you,
Ashok Kumar.
Lakshmi, for all
Yeah,
the
thank you for
participants.
nicely summarizing this last half an hour discussion. Thank you very much. And the students, and I believe that they are inspired to read more. They will never stop reading. They will go on
Yes.
reading.
I just want to add here that all these recordings are available on the ICOG website. This one also and previous months also. So you can definitely take advantage from those recordings also. So, sir, in the end, I take my, this is my humble duty to say thank to all my examiners, all my teachers, my faculty, and the office bearer of ICOG and FOGSI for this ICOG tutorial for the benefit of all. Thank you very much. Thank you, JM Madam. Thank you, Dr. Seema. Thank you, Dr. Apurva, Dr. Urvashi, Dr. Sheila Jamal, and all our students from DDU and from SN Medical College, Agra. And Dr. Ashish sir and Dr. Hafizur Rahman are always with me to organize this program and this tutorial. Thank you very much. And in the end, I would again thank our chairperson, Dr. Lakshmi Shrikande, and our FOGSI president, Dr. Rishikesh Pai sir, for all the support and guidance provided by them. Thank you very much.
Thank you. Thank you.
Thank you, Dr.
Please
Ashish.
stop the
Thank you.
recording.
Thank you. Thank you.
Is the recording stopped?
Yes.
Didn't hear the announcement.
We are waiting for the Mr. Jignesh, host. Have you
Yes,
stopped
sir.
the recording?
Stop the recording,
sir.
please.
It is stopped.